Hello everybody, we're ready to roll? Hello everybody, thank you so much for joining us today. Have you all been involved in Research Week this week, one way or another? How's it been? Good, and I hope those of you listening online have also had a chance to listen to some of the sessions, and really good to see them recorded as well, so that there's a chance, if you've missed something, you can have a listen, as I will be over the weekend. So I'd like to start, as we do all of our important events, by acknowledging the traditional owners of the land on which we're meeting today, and here in the Adelaide Plains, that is the Kaurna people. And I'd like to pay my respects to elders past, present and emerging, and recognise and respect the Kaurna cultural heritage, beliefs and relationship with the land, and acknowledge that these things are of enduring and continuing importance to the Kaurna people living today. Just before this session, Professor Burston and I were reflecting on the Chalmers oration yesterday. Did any of you get a chance to attend? Yeah, and I was just saying that, you know, it was really sort of, I don't know, sobering just to hear those statistics. And to also reflect on some of those diseases that you would not expect in a developed nation to be prevalent in so many of our communities in Australia. And being a Kiwi myself, same in New Zealand. There are many disadvantaged communities where you see diseases leading to things like rheumatic heart fever so prevalent, and it really does give you pause to thought about, what can we do differently? Well, of course, one of the things we can do differently is what you're all engaged in, and it is that critical inquiry through the research process that can bring to light some of these answers that have been eluding us over time. So I encourage you all in your research journey. So I'm absolutely delighted to join you on the last day. Apologies, I missed the first day. I was at home, a bit of an overshare here with viral gastroenteritis. And can I just say, having not had gastro before, when people said you've got people that got gastro, I thought, I'll get a grip. What's a bit of diarrhoea and vomiting? Can I just tell you, it was humbling. My husband did conclude having to stay home with me because, I was a bit faint and overly dramatic, that I could moan for Australia because I did spend quite a bit of time moaning. Anyway, so I'm glad to be here with you all today to see out this fantastic research week. So what a great week it's been. Look, I think the approach that we've taken this year, Andrew, has really proved to be popular. So it's some of the more intense thinking work at the beginning of the week, the fabulous oration sort of in the middle, and then leaving us to have a celebration today. And that's what it will be today, a celebration, as we also hear from our keynote speakers today. So, I did say to our keynote speakers today, I'm going to stand up first and say some nice things about them, and they said, oh, you don't have to. I said, all right, I won't then. And then they went, oh, well, you could say one or two. So we're very, very fortunate today to have two speakers here who are world-renowned researchers and leaders in their field. We'll be hearing from Professor Danny Eckert and Professor Bob Adams, who are talking to us about the very hot topic of sleep health and giving us a sneak peek at their upcoming 3-part television documentary series. Yes, they are not only world-renowned, they're going to be YouTube and TV stars shortly, on the novel approach to sleep medicine titled Australia's Sleep Revolution with Dr. Michael Mosley, which will be aired by SBS. Danny, as many of you may know, is an NHMRC Leadership Fellow and a Matthew Flinders Professor at Flinders University. He serves as Director of FIMRI Sleep Health, Adelaide Institute for Sleep Health, where he leads a comprehensive basic sciences and translational research program comprised of over 60 multidisciplinary clinicians and sleep researchers. I've had the pleasure of visiting the team. And when I went through on my first visit, I think one of the teams was meeting, and I think you had engineers, psychologists, you had researchers, and I think there's about 9 different disciplines around the table that really struck me as being so impressive in terms of that true multidisciplinary approach. You know, sometimes we talk about multidisciplinary, don't we? But to see it in action and to see the results should really give us all pause for thought about the work that we're doing and making sure that we're really bringing in that true multi-D approach, and I'm sure you'll touch on that today. So his research program focuses on identification of the different causes of sleep apnea, optimisation of existing therapies, and development of new tailored therapies. Robert is principal investigator of the North West Adelaide Health Study. He co-led the process of harmonisation with the Florey Adelaide Male Ageing Study, which included over 2,000 men aged over 35 in the male androgen inflammation, lifestyle, environment and stress cohort. Fortunately, that acronym is MALES, which is quite good, isn't it? He is also Chief Investigator on the NHMRC Research Excellence National Centre for Sleep Health Services Research. Following Danny and Bob's talk, you'll be able to ask them questions using the Slido code up on the screen. So please join me in giving them both a warm welcome for the keynote today.
Oops, wrong one.
Sorry about that.
Clearly gut science is something on everyone's mind, which mercifully not mine, so you won't hear anything about viral gastroenteritis here. Thank you, Kerry. We have a number of disclosures which we'll briefly go through. I would also like to add recognition that Flinders has campuses throughout the Central Corridor of Australia, and to acknowledge the many lands that we work on and pay tribute to the elders past, present and emerging of a number of Indigenous peoples. So we're going to talk about a few things here today. One, initially the scope and consequences of sleep problems and how we've been starting to use some new technology to better define these problems. And then a little bit more around the multidisciplinary approach, using a number of different areas to try and perhaps expand the ways we are trying assessment and managing sleep disorders in Australia. So, sleep is a problem. It's one of the 3 pillars of health along with diet and exercise. It has significant contributions to make towards cognition, cardiac, metabolic and mental health. And it cost Australia a lot of money. This report originally was said to cost Australia $66 billion, most of which is around lost productivity. It has significant impacts around that. And the report, along with a few other things that we did, contributed to a parliamentary inquiry 3 or 4 years ago now, which made a number of recommendations about how this might be improved. And the government recently recognised that some of these were good ideas without necessarily contributing an enormous amount of funding towards correcting that. But we are hopeful of moving that on over the next few years. I think the other area, as I mentioned, that productivity is an important part of the problem of sleep and sleep problems is that we're shift workers. I'm not going to spend a great time talking about shift workers other than to point out that sleep problems are not just a problem of going to sleep and waking up. A deficiency of sleep, however obtained, is a systemic problem. It's a problem that relates to your brain, your gastrointestinal symptoms. It increases risk of cancer. It has effects on reproduction. It has major effects on cardiovascular and metabolic health and also on mental health. So the commonest cause of a sleep disorder is obstructive sleep apnea, where repetitively overnight the upper airway is occluded and then opens up. It leads to recurrent falls in oxygen saturation. It leads to substantial intrathoracic pressures and effect on cardiac function and fragments sleep. The other most common disorder is that of insomnia, which many of us sort of think is a bad night's sleep. It is actually significantly more than that. Insomnia is a problem where you have difficulty getting off to sleep or staying asleep, but also has significant daytime impacts. Again, regarding mental health, irritability, function, and often impulsive or aggressive behaviour. As I mentioned, OSA impacts more than sleepiness, and it really is the systemic effects are mediated by a variety of things, including oxidative stress, inflammation, endothelial dysfunction, and vasoconstriction, and that naturally, as you might expect, contributes to problems across the organs. And so you get a 2 to 3-fold increase in car accidents, in hypertension, dyslipidemia, cardiometabolic disease, mood disorders, depression, and in mortality. Insomnia, as I heard, has a number of problems, but one of the things it certainly contributes to is depression. And that difficulty with sleeping is often the first symptom of depression that occurs before the mood disorder. And so over a period of time, there's a 2 to 3-fold increase in significant clinical major depression following the onset of insomnia symptoms or difficulty sleeping. And the paradigm, however, that we assume that the sleep problem is secondary to the mood disorder may not actually be an accurate one. The two of them together do occur, and when they do, that is particularly troublesome. This is data from a paper by Bastien Lachey, who I'll talk about, done some more work. He's an engineer as part of the multidisciplinary team. He's a postdoc in our institute and recently got a NHMRC investigator fellowship. And looking at large data this is from the Sleep Out Health study, but has been replicated in other large studies as well, in that the mortality risk and cardiovascular disease risk over a period of time is actually far greater in those with a combination of insomnia and obstructive sleep apnea than either condition alone. Okay. Which would not be a problem if these were rare. However, they're not. They're actually extraordinarily common. This is data from the RAIN study in Western Australia and shows in middle-aged men and women the prevalence of significant sleep disorders. The blue people are significant obstructive sleep apnea, the green is insomnia, and the green and blue are combinations of the two. And around 40% of middle-aged Australians have a clinical sleep disorder. In men, that's more commonly sleep apnea. In women, it's a combination of sleep apnea and insomnia. Thankfully, there is a very effective treatment, at least for sleep apnea, for both conditions. Sleep apnea, the commonest is used is CPAP, which I'm sure you've all seen and heard, which is, as one of our patients described, wearing a Darth Vader mask at night with oxygen going through it. And it significantly reduces the disease severity, daytime sleepiness, blood pressure, motor vehicle accidents, and also depressive symptoms. So far, so good. Insomnia treatment, again, improves insomnia, but it also decreases depressive symptoms as well. And in fact, having insomnia persist after you've managed depression in some other way reduces the effectiveness of insomnia over time, of depression treatment, over time. So, what's the downside? The downside is that CPAP is poorly tolerated by a large proportion of people for whom it is indicated. This is data from US real-world data from 180,000 people over a significant period of time. And it shows amongst even those who started CPAP and were able to tolerate it initially, by about 3 years, only 50% of them are using it more than 3 hours a night. And we think that 3 hours a night is insufficient to successfully manage their sleep apnea. So we have a problem of people not initially wanting to use it because for a variety of reasons, and then if you get on it, only 50% are using it effectively a little while later. And that data, the other curve there, is really only showing that this figure hasn't improved over the last 20 or 30 years. So we are stuck at about 30, 40% effective tolerance of CPAP over the longer term. For insomnia in Australia, the guideline recommended treatment is cognitive behavioural therapy for insomnia, which is a treatment focused on both improving cognition and behavioural aspects of managing it. It's very effective, it works well. The problem being that the only people who get to use it, I'm not good enough to use the clicker, which is a shame, that the middle graph, that little blue line ticking along there at the 1 to 2% level is the amount of people with insomnia who get a referral to a psychologist for management with cognitive behavioural therapy for insomnia. And so again, effective treatment is essentially inaccessible for most people. So, why do we need a new approach? Well, I think you can see from this is that the current one-size-fits-all, where if you have sleep apnea, you get given CPAP and go away and it all works well, is cumbersome, it's time-consuming, it's costly, and as we've seen, it fails many people. And so the first trick is you run through the CPAP process. Some people don't like it, some people don't use it, and we find out we need alternative therapies. And the first line of alternative therapy would be an oral mandibular device, which acts to move the bottom jaw forward on the top jaw, creates more space at the back of the throat, and is actually a very effective treatment, as this trial done in Australia sort of 10 years ago demonstrated. However, again, only 8 to 10% of people with sleep apnea are offered this as a treatment because it's difficult to get. Certainly getting anything other than the most urgent dental care at a public dental hospital, as we know, is a difficult thing to do. And if you have private insurance, you've got to pay for it, and they're $1,500, $2,000 a throw. So it's difficult to get done. The alternative then moves to other therapies, and one of the ones that has been tried, certainly past and future, is surgery. And again, for selected patients, very effective. Again, a trial from Australia, certainly in this institution, contributed to that significantly. And we find in selected patients, multi-level surgery for the upper airway works very well. So, we think that despite the marketing ploy there, I'm not sure terribly many people are very attracted to a CPAP machine in bed at night. But you know. Unfortunately, far more people experience CPAP more like this. And that we really feel we need, and there are good physiological scientific reasons for adopting a more nuanced approach to this issue. Sleep apnea is a heterogeneous disorder, and so an optimal therapy will likely vary between people, in which case a precision medicine approach is indicated. Okay, so what I'm going to move on now is to talk about some newer technology that we've been using to try and define the problem a little more accurately. And this is work that Bastian led from our lab, and it uses a device from a company called Withings, which is an under-mattress device. It looks like a piece of A4 paper. It slips under the mattress. It has pneumatic and sound sensors and gives you a pretty accurate representation of heart rate, breathing, noise, movements. And from that, you can derive algorithms to get a good idea about sleep apnea, apnea-hypopnea index, and its sensitivity and specificity of about 88% compared to an in-lab PSG. So it's not perfect, but it's pretty good for a $150 device that slips under your mattress and can, importantly in this case, measure sleep continuously. And so what Bastian looked at was 60,000 participants from around the world using nightly in-home data, mostly men, because men are the sorts of people that are persuaded to use the tech and probably also are more prone to getting elbowed by partners that they may be snoring and sleeping poorly. And what he found was that if you take one night recording and then compare it with multiple nights, because sleep apnea and sleeping varies night to night, you can find that there are large numbers of people that are misclassified as mild, moderate or severe, depending on the night that you pick. And between 20 and 50% of anyone will end up in the wrong category, depending on the night compared to measuring them over multiple nights. And the most troublesome part of that is that if you look at the even severe sleep apnea, which is the purple curve there and the blue curve, over about 25% of people would be misclassified as either mild or maybe moderate on a one-night study versus if you record them for 7 to 14 nights. And so there's a risk of a number of people being undertreated and undermanaged. The converse risk is there's quite a few people who have mild or no sleep apnea but get on a regular basis, but get recorded as having significant sleep apnea if you take one night. So there's a lot of people that might end up being treated who probably don't necessarily benefit from that. And this kind of shows that if we conduct multiple trials of averaging your AHI multiple times and we can find out which one of those would be accurately located, there's about 40% misclassified on this one night. The more nights you do, the less likely you are to misclassify people. The risk being, of course, is that that can then lead to inconsistent findings with regard to risk around things like hypertension and cardiovascular disease. And so one of the things that we've seen here is that the SAVE trial, led out of SALHN at the time by Doug McAvoy, largest trial to date to examine the effect of CPAP and cardiovascular risk, was a negative trial, found no impact. And that was always assumed, or has been assumed for some time, that the problem there was that the duration of use of CPAP was about 3 hours a night and they just weren't getting enough to have much impact. And that's probably not an unreasonable thing to think. The other way of looking at this, if we consider the significant part of night-to-night variability and who is at risk, is that we really had very little idea, using a single night study, of who necessarily was at risk of having a problem. And so it may well be that the people who were given CPAP, many of them were not going to benefit from it in terms of cardiovascular risk, and there may have been people that were left out of the trial who would have benefited but weren't enrolled because their one night didn't classify them properly. And one of the things that we think we really need to think about in the future is ways of enrolling people into studies that are demonstrated to be higher risk through their variability over night to night. And we can see that here by work where Bastien looked at the risk of hypertension developing in this large group of men over a period of time, really only 12 to 18 months, and found that the group down the bottom, the quartile 4, are the group with the highest degree of night-to-night variability in their sleep apnea, their AHI. And even those with mild sleep apnea, whose variability in sleep apnea most nights is only between 5 and 15 events per hour, we would call that mild, are at significant risk of developing hypertension over a relatively short period of time, and are at greater risk than people who have more severe sleep apnea but have it regularly. So the night-to-night variability looks like it's a phenotype that we think is important with regard to cardiovascular risk. And that kind of has come out of the ability to use new technology, bigger numbers, and examining these questions in a different way. So the problem we kind of have here is that sleep apnea and insomnia are very common. We know they have major adverse health effects and significant personal and societal costs. They are, however, heterogeneous disorders that have tended to all be lumped under one banner previously and managed in a kind of one-size-fits-all approach. The pathways to diagnosis and assessment are problematic and difficult. We have effective treatments, but there is limits in getting them due to access, due to costs, but also tolerance of using them. The one-size-fits-all approach is suboptimal, and we think a more precision medicine approach is therefore justified. So, what we're going to hear from now is Danny's going to talk about some of the things that we've been working on, and especially he's been working on, in expanding the role of other ways of looking at this.
Terrific. Thanks so much, Bob, for that very nice overview. So yes, I'm going to switch gears a little bit and talk about how we can overcome some of the problems that we've heard about, and a little bit of physiology here before we get into the practical implications. So when I joined the field over 20 years ago now, We looked at these MRI images. We look at the image on the left. These are awake MRI images of the upper airway. We would think that that person on the left does not have sleep apnea because their airway is nice and wide and open, whereas that person on the right, where there's a crowded, narrow airway, is more likely to have sleep apnea. But sleep apnea is much more than just an anatomically driven disorder, as we can see here. So these are techniques developed by my colleagues in Sydney, MRI tagging. We can see that, yes, if you just take a static image of this airway, it is narrow and crowded in this obese individual. But look here, their muscles are working fantastically well to keep that airway nice and open. So in fact, despite the fact they've got an anatomical vulnerability that would otherwise predispose them to sleep apnea, because the muscles work so well, this person doesn't actually have sleep apnea. And of course, the reverse is also true. You can have a little bit of an anatomical problem, but if your muscles aren't working well, that can cause sleep apnea. We see these other types of patterns. Here's someone where you get a bit of dilation at the base of the tongue during early inspiration, but then you can see the uvula, a little punch bag moving back and touching the posterior wall, and that person's got moderately severe sleep apnea. And here's someone with very little motion of their dilator muscles at all during quiet breathing and a very narrow airway, and this person's got severe sleep apnea. So this is kind of the basis that's unlocked this personalised or precision medicine approach for sleep apnea. Yes, anatomy is important, but these other factors, and I talked about the muscles there, how easily you wake up when when your airway narrow, or what we call arousal threshold, and really the fourth trait is how sensitive you are to carbon dioxide or your control of breathing, are fundamentally important in driving the presence or absence of this very common disorder. So here's how we go about measuring it in the physiology laboratory. We insert these fine wire electrodes into the largest upper airway dilator muscle, genea glossus and tensor palatini. You can see those little wires coming out of the mouth there. And we measure airflow and airway pressures, clearly not translatable in a clinical setting, but this has allowed us to sort of unlock these different mechanisms. And this is where we've landed. So it turns out, yes, to have sleep apnea, you have to have some degree of airway narrowing or anatomical vulnerability, but that varies substantially between people. A third of people are light sleepers and they just wake up too easily. A third of people are too sensitive to carbon dioxide, and another third of people with sleep apnea are unable to generate any activation of these dilator muscles in the airway. And overall, it turns out that 70% of people with sleep apnea have one or more of these non-anatomical factors that are going on. And the reason that this is important is this now unlocks all these other treatments beyond just targeting anatomy, if we're able to estimate accurately what these traits are. And this is a schematic to show this. So these are all therapies beyond CPAP. The ones up top are things that target the anatomy trait. And here's some other emerging therapies that target these other traits since we've been able to discover them. So the oral appliance is the mandibular advancement splint. We've got surgery, position therapy, just putting people on their side can help the airway a lot. And of course, weight loss in those who are obese. Remembering that actually half of the people with sleep apnea out there in the community are not in fact obese. Okay, look, I won't go into any detail here. It's just to say very quickly that if you actually measure these traits and estimate them, at the moment, one of the problems with these mouth guards is only half of the people get a full therapeutic response. And if we knew about their physiology, we can get those numbers more up to 80–90% accuracy. So if we have estimates of those, we can change that from being a toss of a coin to really being able to accurately predict in most people. Actually, the same is true for CPAP. So I mentioned there that many people have, Bob showed the data about tolerance to CPAP. 50% are unable to tolerate it. And it turns out that if you're one of these people with the low arousal threshold physiological trait, of which about 80% of people, or more than 80% of people who are not obese have this physiological trait, they do particularly poorly on CPAP. So they're basically light sleepers, putting the mask on, they're unable to sleep properly, and there's very low CPAP uptake and compliance when we follow them up. We looked at that systematically several years ago now, and then colleagues in Yale have replicated that in 2 additional cohorts now. So really, the idea is if we know about these different traits, we can improve success rates with the existing therapies, CPAP, oral appliance therapy as examples. And this article really summarises those different approaches. But what about these new therapies? What else can we do beyond those ones that are really targeted around the anatomy? Well, we've got things like hypoglossal nerve stimulation, and we're doing an exciting study now with surgeons here at Flinders to look at novel technology, implantable devices, upper airway training, and we've also been heavily involved in, we have no drugs to treat this very common disorder at the moment. But we're on the cutting edge of getting some. And here's what happens. So if you look at those upper airway muscles when you go off to sleep, the moment we go off to sleep, there's that rapid reduction in airway muscle activity. And look at what happens to breathing. This happens to all of us as we doze off to sleep. Breathing goes down almost automatically from that alpha to theta transition. So if we knew neurochemically what was driving that reduction in muscle tone, we should be able to give a drug and reactivate those pathways and activate the muscles. And here's a study that I was involved with colleagues in Boston. And what we did based on animal data that suggested that the noradrenergic and muscarinic systems were particularly important, we just took 2 drugs that are already approved with those properties. We repurposed them, put them together, we studied the physiology, and this drug, atomoxetine, and the other antimuscarinic, oxybutynin, basically activated the muscles 3-fold during sleep compared to the placebo in these 20 or so people with sleep apnea. And the way that this works is shown here. So we think the oxybutynin is working there at these hypoglossal motor neurons via the acetylcholine pathway, and versus the atomoxetine, I should say, is working on the norepinephrine system, whereas the oxybutynin is working on acetylcholine as shown here. So we were very excited from this proof of concept study, and you can see here's what happened. Here's the way we measure sleep apnea severity. People went from having 30 or 40 breathing events per hour to around about 10, which we would consider now within the sort of normal or mild range. These are just single night studies. Their oxygen levels got better, and this was better during REM and non-REM sleep. So this has now led on to lots more work, the development of a Boston-based company, and they've just enrolled actually yesterday the first patient in phase 3 testing. So, we're hopeful that this will be the first approved therapy for sleep apnea. Here's another target, completely different, that we did here at Flinders, was looking at the opposite. When you go to the dentist, you give some lignocaine, you spray that in the airway, and it numbs the airway. This is the opposite. Here we're using topical potassium channel antagonism, so a spray to try and activate these robust reflexes that we have in the airway to try and enhance the protective effects. So we just gave some nasal spray, and in fact in this study led by Amal Osman, it was a very detailed physiology study. We carefully measured the collapsibility of the airway when we sprayed with placebo, different doses of a spray. We gave drops. We even put an endoscope down and then sprayed directly on the areas where we think these receptors are. And long story short, this agent made the airway less collapsible and theoretically should help to reduce sleep apnea severity in some individuals. And it's about the effect size of putting someone on their side or supine avoidance therapy. So there's just a couple of examples. I don't have time to go into all the details, but the other thing, we know that this is a very heterogeneous disorder. Things like asthma, there's a muscular cause, there's an inflammatory cause. We treat that with dual agents. Sleep apnea, we're left with monotherapy. So here we've actually tried to combine some of these targets in this study to deliver combination therapy. So again, this was work that was dually led here in Flinders and in Sydney. And what we did was we took people, over 100 people who were prescribed one of these mouth guards to treat their sleep apnea. And as mentioned, it's about a toss of a coin as to whether or not that's going to work for them or not. So what we did is we fully phenotyped them using those techniques that I showed you at the start with the EMG wires and so forth. Yes, indeed, roughly half of them were treated just with the mouthguard alone, but we then used the information from the phenotyping to bring them back and give them one or more targeted therapies based on their physiology. The goal really being here to treat everyone without needing to use CPAP. And indeed, this is Akia Ashar's work. She's now doing her postdoc at Harvard, but did her PhD here. And what she found was in these people who didn't have we brought the people back that weren't fully treated with the mouthguard alone, and usually these people are stuck. They got no other option. We then just gave them a simple device to keep them off their back, and we were able to treat half of them alone just doing that. So this is readily available. We can do that now. And then we did our novel interventions based on their physiology. We gave oxygen to lower their loop gain or their control of breathing. We gave some drugs for the muscles. And finally, as a last resort, we used CPAP. And effectively, we only needed that in 1 or 2 people, and we were able to effectively treat everyone. We've also developed these tools, these algorithms to try and predict, just using standard clinical data and sleep study information, what are these 4 traits and who needs what therapy. So this is a very simple innovation that we've developed that we're now using in our practice. And here's now what I want to share with you, which is the study that we did as part of this television series. So it's we didn't name it Australia Sleep Health Revolution, but it really gave us a chance to bring all the pieces of our research program together. And thank you, Kerry, for mentioning that multidisciplinary aspect, because that was fundamental to what we did here and the reason that it worked. So let me just talk you through what we did. So unfortunately, because the series is not going to come out until next year, I can't show you footage now because it's still under embargo, but I can share what we did in terms of the design. So we actually run this as an ethically approved study. And our goal here, we enrolled 30 of the nation's worst sleepers. These are people you would never usually enroll in a clinical trial. They've failed pretty much everything else. Some of them had insomnia for 20 years or more, insomnia and sleep apnea for others, and some just sleep apnea alone. We recruited them, we did some pre-screening, we brought them in, we threw a lot of technology at them, some of which Bob has described. They either did an in-lab or an in-home study. We did multidisciplinary meetings twice weekly with that team, the scientists, the psychologists, the sleep and respiratory docs. We reviewed the information that was coming in, all this information we usually would not get in routine clinical care. And then we brought them back to 8 weeks later to see if it worked. And really the goal here was to deliver this personalised sleep disorders therapy using these cutting-edge diagnostic and monitoring tools, including physiological endotyping for sleep apnea and in-home novel monitoring technology, and these latest treatment approaches, including combination therapy and these emerging therapies to reduce sleep disorder severity in as many people as we could in the cohort. Really, we wanted to treat them all. And we flipped the model. We only use CPAP as an absolute last resort for those with sleep apnea. We hypothesised that this individualised treatment approach would, and based on better diagnostics and physiological characterisation, would allow us to tailor therapy and really reduce the insomnia severity in those with insomnia and the severity of sleep apnea in those with sleep apnea, or the combination of both. So here's one of the photos with some of the producer. And so we had cameras following us around for 3 months, which was kind of tough, particularly for the poor psychologists in some of these sensitive sessions. But we got used to it. You don't see it in here, but there's cameras in the background. Twice a week, we would meet, review cases, all the physiological data that was coming in from the technology, and we used that to make decisions. So in addition to that primary aim, we also hypothesised that our multidisciplinary approach and this targeted treatment approach would also improve the things that matters to the consumers. You know, their daytime sleepiness, their alertness, their mood, their well-being. And here's what we threw at them. So everyone had one of these Withings mats. They all had a Fitbit. They They had oxygen rings. Some of them swallowed these body clock pills that allow us to accurately measure body temperature and estimate circadian rhythms that give us a very accurate estimate for several days. We measured blood pressure in the home. Every day they use this little app to check in on their well-being. Just takes about a minute. They fill out how you're feeling, how well you slept last night, emotional, mental health, physical well-being. Some people went home with an oxygen ring as shown here. And then they also came into the lab and we did some physiology to figure out what was causing their sleep apnea and use that simple algorithm to make treatment decisions. And I should say, this was kind of nerve-wracking. We hadn't done this before, and then we were doing it as part of a 3 one-hour television series. So it was an incredible team effort and a nerve-wracking one to get through. And we had to build all of this on the fly. But as you will see when it comes to air, I'm pleased to say it worked out quite well. And here's the targeted treatments that we applied. So some of these developed here at the Adelaide Institute for Sleep Health, the retimer therapy, the THIM alert. So this is to deliver a therapy for people with insomnia who have sleep onset insomnia issues. The retimer, you might have seen Mick Jagger using these in the past. He's tried them out to try and reset your body clock, and for those people with circadian malalignment, and it helps with jet lag and things. Our frontline approach was a dental approach, and here's our dentist, Jeff, here, who ran a clinic. That little device on the neck gives you a little buzz to stop you sleeping on the back, so that helps as positional therapy, or you can put it around your chest if you prefer. We gave these novel therapies, pharmacotherapies in some people, or oxygen therapy, and as mentioned, CPAP as a last resort.
Sleep awareness.
Okay. The other thing that we did that also proved to be quite impactful, and Bob mentioned the parliamentary inquiry that many of us were involved with into sleep health awareness. Fantastic inquiry. We're sitting on the bench or gathering dust because the pandemic came along. And perhaps not surprisingly, this program, we went to Canberra, and Sutapa and I and Alison went and we ran a little study in several prominent politicians, and we measured a bunch of physiology and health parameters at the start of the sitting period and after 2 weeks. We used a lot of that tech in the home. We had continuous glucose monitoring. We measured their blood pressure, reaction times, before and after this. And again, I can't share the results because it's under embargo, but needless to say, the results were interesting and enlightening for the politicians. And this will hope, and we now, as a result of perhaps I would say the television folks getting in contact with Mark Butler, his office has now responded to our parliamentary inquiry. And as Bob mentioned, they endorsed all of the recommendations, although we're now waiting for action. So it may not be our last trip to Canberra.
Sleep Awareness Week.
Great to have you here, Michael. Really important for everyone to understand just how important sleeping well is for a happy, healthy life.
Absolutely, and I have to say it's been absolutely outstanding being here. Terrific team of scientists, and I think that what we're doing here and the film we're making here is going to be incredibly important.
Really appreciate your support and raising awareness for the importance of sleeping well.
Sleep well!
Sleep well.
So that was a little goofy thing we did for World Sleep Day, and but yes, we are excited about the program that's about to come out. We're very happy that there's no more cameras with us, and we've been able to get on with our business. But thank you very much for the opportunity, and we can only do what we do with the collaboration with our clinical colleagues, and which has always been at the forefront of the questions that we ask and our research program. So thank you very much. And there are some photos of our fantastic team. It's everything we do here is very much a team effort, and I want to acknowledge the team as well.
Questions?
Great talk, guys. I missed how you apply the lovely work, and great for Flinders for this documentary, in Australia. I missed, Danny, how you apply the antimuscarinic. Was that through the mouth, or was it presumably not oral? I guess a simple question from a pharmacology background, probably one of the worst things is to block muscarinic receptors in the heart and other organs. Can you control where you deliver the dose?
Yeah, look, in those, we just took the oxybutynin, which was, orally as a pill.
Okay.
And yes, you're right. It hits many targets. This was very much proof of concept. And the latest study that's running now, it's been tweaked a little bit to optimize the targets, if you like.
Okay.
But off the shelf, we took the agent and saw that effect. Yeah. Yeah. Accuracy. Okay, so there's a question here about the accuracy of the wearable devices such as the Oura Ring that provide individuals with sleep metrics. Look, I can't comment too much on the Oura Ring because we actually didn't rely on that too much. We were trying to test that out ourselves in this context, so we didn't actually rely on that one too much for this study, but we did actually validate that Withings mat in our own hands because, to be honest, we didn't actually believe it ourselves that a mat that simple could give us 80-90% accuracy as an overnight sleep study. We did the study, we found exactly the same predictions as they published. So that gave us confidence in that particular parameter. Look, what I will say is what we found by putting all these technology together, they each had their advantages and disadvantages. By having that combination, we were able to get a complete picture of what was going on that really helped us clinically. And maybe you want to comment on that too.
Yeah, I think the answer is depends what you mean by sleep metrics. I know many of them sort of say, you can give you sleep staging, sleep architecture, and you get X% of deep sleep. Those numbers are probably less reliable than things like oxygen and whether you're breathing and what your heart rate is like. And the combinations of those, as Danny says, depending on what you're getting, gives you a much better picture about your sleep, but I wouldn't rely on it to say you're getting 15% REM sleep every night.
Yeah. Sorry, another question. Yes.
Yes. There are sort of more general things. Any weight loss will tend to help. And it doesn't need to be an enormous weight loss. 10 kilograms, 5 to 10 kilograms can produce a significant reduction in your apnea-hypopnea index. Some of the things that we think lead to night-to-night variability includes alcohol intake, which clearly can affect it, smoking. So the sorts of things that contribute to general health and general lifestyle improvements will give you improvements in your risk of sleep apnea.
And I'm just thinking also of Johannes's work, another NHMRC investigator recipient in our team who has some nice studies showing that not just the diet, but the micro and macronutrients, plant-based diets, these things also lower your risk of sleep apnea.
Yeah, composition of the diet and healthy plant-based as distinct from some of the unhealthy plant-based, processed foods are clearly not terribly good for you either.
Very good.
We're done.
Thank you.
Thank you.
No, sorry. Yeah.
Yeah, valid question. The flip side of the health revolution is that I think 3 points to make there. Danny pointed out that these were not difficult patients, but very difficult problems to solve. So this is the very, very highly specialised end of the spectrum. And we think that deserves a highly specialised approach. One of the other studies we're running is a NHLC partnership grant, which is aimed to expand the capacity of primary care to manage what we would call non-complex sleep apnea and insomnia. And that's really designed to provide primary care with the tools and the training and the gear to manage what is the majority of sleep apnea patients and the majority of insomnia patients who are more straightforward. And so we didn't have time really to go through that. But I think the approach that Danny's talking about here really is more for the, say, 50% who don't tolerate the CPAP, for the complex patients who have OSA and insomnia, and for those who are developing it for reasons that are more difficult. And that's the group that we think the highly sophisticated approach will be more effective for. It's a bit like, I think, we make the argument where diabetes was 20 or 30 years ago, where everybody with diabetes saw an endocrinologist, in 1980. Now I think a GP would think they'd failed if they sent someone with diabetes to an endocrinologist most of the time. And that's because the capacity to manage them in-house and in primary care has been enhanced, and it's really only the more complex and more difficult to manage cases that go to the endocrinologist. We think that's where sleep will be in 10 years. We hope that's where sleep will be in 10 years' time.
And just lastly on that, the new MRFF that we've got, where we'll be rolling out these treatable traits for sleep apnea approach, we're going to integrate that into SALHN, and we think that we can automate a lot of the process that we've seen here. So better use of the technology, a lot of the automation, just smarter the use of what we're already out there will actually open up access to care. So we think we can actually open the door with more access to care and be more sophisticated just by doing things a little bit more sensibly and physiologically based rather than the current one-size-fits-all trial and error. So we think they actually go hand in hand. Yeah.
I've just got two questions for you. Did you sign up to an ongoing deal, a bit sort of like the Kardashians? Is it going to be like the Bob and Danny show, or Keeping Up with the Sleep Team or something like that? Did you secure a deal?
This will be our first and last.
First and last, they're saying, for those of you online. Shame. Missed an opportunity there. And my other question for you is, so for those of us with significant others who snore, and they get a small prod in the night, is that a health, something that's improving their health?
Maybe getting one of those little devices instead. Yeah.
I heard that improves their health. Did you all hear that? I think that improves their health. Anyway, so...
The positive elbow sign.
The positive elbow.
But not necessarily.
Right, I'll take that to the bank. Okay. No, thank you so much. And look, fantastic, fascinating work, world life-changing work, well done. We're extremely proud to be, associated with the work that you do here at SALHN. So can we just have one more round of applause, please, for the team? Thank you for being our final keynote. Can I invite, please, Professor Burston up to introduce our next guest?
Thanks so much, Kerry, and thanks very much, both of you, for stepping up and giving a great keynote for us. Look, it's my pleasure now to ask Nick Spencer to come down, I think, and Marcello Costa. So Nick, Marcello has been a Matthew Flinders Distinguished Emeritus Professor, retired in 2022. He's been here for 47 years in this place, and I think if you go, if you get a chance to visit our research hub and you go to the library, you'll see there on the wall the very first abstract presentation from the new medical school, and I think Marcello was our first author on that, and so it's really something to behold. So I know Marcello will say a few words, Nick will say a few words. We'll hear from Nick about Marcello, but just to tell you that Nick is very distinguished neurophysiologist himself. We're very lucky to have you here, Nick, so thanks so much for doing this, and I look forward to hearing about Marcello from you and from Marcello. So thanks so much, Marcello.
Thank you so much, Andrew, and the organizer of this event. I guess that I need to start this. I guess I just press this, will go. Fantastic, if it does. Well, a lifetime in 2 minutes. Indeed, how easy is this book just appeared on my desk yesterday, as usually happened to printers and publishers. And I wrote this book since I retired last year, with the help of a lot of people, and in particular, of course, I want to acknowledge Peter Arnold, a good friend from Sydney. He corrected my otherwise very mediocre English, so you owe to him the fact that perhaps it's more readable than not. And of course, I came to Australia because of Jeff Burstock. He passed away peacefully a couple of years ago. Jeff Burstock attracted me to Australia in 1970 in Melbourne, and he is with Naomi and my good wife, Daniela. Of course, there you are. I started about 6 years ago with an interest in how the nervous system works. I was still a medical student in Turin. And then I published in 1965 the first paper on the gut innervation. I was still a medical student. Then, of course, I known Daniela since then, so quite a long time, same time as my scientific life. And then, of course, I spent the rest of my life. 52 years ago, we arrived to Australia, and indeed, just after I got married with Daniela. And I did 48 years of research at Flinders. In fact, it was here in 1975, probably in this very lecture theatre, I gave my first lecture to the medical students. So my advice to the medical students was that my better contribution to medicine was not to become a general practitioner. And so in a way, I now owe to many of them the fact I'm still here. So all my GPs and specialists are all my ex-students, so I cannot really complain with them. When I arrived to Flinders, there were some quite interesting foundation professors. You can see there Laurie Geffen on the left, John Chalmers. You've seen him yesterday at the oration. Michael Berry and Andy Roger left us a few years ago, but quite an interesting set of young professors, very, very original in their thinking, and I think they left a mark, as you probably all know. Indeed, I was lucky that the introduction was not written by me, but by a dear friend from England. You can see this is the real content of my book. Made mostly of questions, which I started, I gave some answers, and I still keep asking questions. And of course, Laurie Geffen, the foundation professor of Flinders in physiology, brought me to Flinders. And he accepted to write in this, the foreword of this book. So I'm very thankful for him. So I'm going to thank those people who accepted to my comments on my book in the very book, at the end of the book or at the beginning. So Laurie Geffen has been and remained one of my major mentors. And of course, why this doesn't seem to be working now, I'm not sure. Back or forward? No, doesn't seem to be. I can use that. Fantastic. Even that doesn't work. So that's not the first time that I've been interrupted by technology. It's working again. Thank you so much. Yes, indeed. And of course, John Chalmers, that some of you may have heard yesterday, commenting on the oration. He has been a foundation professor of medicine. He really shaped this place, and he has been a fantastic mentor then and now of myself and many other people. You can see here also with Alec. Of course, then I started to work the very day I arrived. The very first afternoon I arrived to Melbourne, 1970, with John Furness. He also was a foundation lecturer here at Flinders, but in Melbourne in 1970, he disagreed with me about some result I published in Italian and French. He was the only one that read them probably. And we argued, and we did the experiment the same afternoon. And for once I was right, and we started a long time collaboration, and he also has written a very kind comment on my book. Of course, I owe a lot to Simon Brooks. He's not here today, but he knows me well, and he has been one of the first postdoctoral that joined me at Flinders in the late 80s, and then first as a young postdoc, and then as my boss. Has been a young and old mentor of my existence. Of course, Bill Blessing, who is also not here today, but he has been. Oh, Bill is here. This happens all the time. When I think he's not there, he's always there for me. Thank you, Bill. we did a lot of things together. We traversed the waters in windsurfing, and we relied on each other, or better, we knew we couldn't rely on each other. That's why we were doing together. But as I share with him a lot of science and certainly a lot of friendship with the family going at the Coorong and around South Australia. So thank you, Bill. And of course, Ian and Judy, who are here, indeed they were also among postdocs of mine and John Furness, and then of course they retired, and they seem to be very happy in their retirement because they have become very well known in their own field, in poetry, Ian, and in painting and drawing. Judy left science, but really never left the good creativity that science left them with. Of course, Phil Dini, who is here, joined us several years ago, and I owe to him a lot of work I've done in the past few years and together. And therefore, I'm very thankful also for the comment that he wrote on the book. But my biggest thank, of course, goes to Nick, who's going to actually officially present the book. But he has been wonderful since he joined Flinders. I joined his lab back into applied research, and I probably produced my best work in his laboratory and the other laboratories that you have seen before. But I also owe a lot to Giorgio Gabella. I haven't seen him for decades. He's in London. He was my supervisor back in the time of medicine in Italy. And he wrote for me what I should have written in my book, which is written in the book, as his word put on me. So he written, the way I have come to see this life story might seem amazing. I imagined that events were just brush strokes, all different color, size, pattern, some done as an authoritarian, other done just holding a colleague's hand. And all these activities are coming together, and there is a picture, an almost complete painting, not ready to be framed, but rather to my liking, he added, in case you wonder. He also wrote the very last words. So these are my thinking, but he put into words, and I owe him a lot, after a lot of time of distance from England to Australia. Of course, I owe a lot to the various really literally hundreds of people that work with me and for me and together. In the last few years, this represents the core of the neurogastroenterologists at Flinders. First of all, you can see here Simon Brooks, his lab, and you can see some Phil Dinning and his lab, and Nick Spencer, his lab. When I say their labs, I was a guest without any responsibility. So it's like going back to your children's home and be able to cook in the evening, live in a mess, having a great dinner, and leaving the whole mess for somebody else to clean it. So it has been a wonderful event, and I must thank, of course, the Mel and Lorraine and Nan, and of course some of the young students like David and Tim and Adam, and of course one of our first students, David Watcher, who has been a surgeon and a senior surgeon, a good colleague. So I owe to them a lot of what I've done in the past decades. But certainly one person is essential, and without whom I would not have done any of this, and this is, of course, my good, lovely wife, to whom I'm dedicating this book. And thank you very much, and Nick, is all yours now.
Okay, well, it's kind of an amazing experience to be standing here, and thank you for this opportunity. And I'm tremendously honoured that Marcello has chosen me of the hundreds of people he's worked with over 5 or 6 decades. You know, I turned 51 this year, and Marcello considers me his grandson, so I'm 31 years younger. And it's been a phenomenal opportunity to have Marcello in the laboratory. So, the book is here. I'm here to officially announce the book. It's available here to look at. Highly recommend it. And for the early career scientists, if I could say one thing, you're not here to listen to me, more about Marcello, but I can't tell you how valuable it is to work with a senior scientist, someone that's made lots of mistakes. Everybody makes mistakes. And in science, you want to minimise them. And the best thing you can do is work with senior people. And I've tried to engineer my career that way, and it's helped a lot. So having Marcello in the lab has been incredible. So I know we're late, we're behind time. I'll just try. It's very hard to summarise a gentleman like Marcello in a couple of minutes. So I'll let the book do that. But Marcello's been here 47 years. I've been here 16. And the way we worked together was I was setting up my laboratory. I'd just come here for a job. And Marcello came in one day and said, literally, what are you doing? And I said, well, I'm setting up to do some experiments on the gut. And there was a 2 or 3 second lag, and he looked around the room and he left. And then the next morning he said, literally, Nick, I'd like to come back into research, end of quote. And I said, fantastic, well, we'd love to have you. And it's been an incredibly productive time. Marcello's most productive period has been from 70 to 82 years of age. And I'm tremendously honoured that that period has existed together. So for everybody that thinks that you deteriorate with age, Marcello's good evidence that that's not the case. Marcello's gone through some of the background, but he's had a phenomenal contribution to science. And before he did that, as a young boy here in Buenos Aires, he's a very talented painter. Here he is, not sure exactly what age, and then he moved back to Turin, a little younger teenager, and attracted a large crowd and some beautiful work, which he's still got, and I've seen in his house, and he received some awards. But he sort of gave up a career in art because he realised he couldn't draw faces very well. But that wasn't the end of it. He was actually a very talented musician, and still is. In fact, I saw him just recently singing, and he's been singing a long time in Adelaide. This is in the Amazon, 12 years before I was even born. And then here in jazz, South American folk, he could have pursued a career, or in jazz, or as a great accomplished singer back in northern Italy. Marcello could have been an explorer. In 1959, he started on the border of Chile and Argentina, where he grew up, and he climbed some mountains which had never been seen by humans. The Serra Torre, and if you look at the YouTube clips, you can see them. He went back in 95 and then in 2005 and experienced the deterioration of climate, unfortunately. Marcello's a very sociable person. You can read in the book, he's got many, many friends, and he had a wonderful way of balancing career with family and friends. And, you know, that's sometimes not that easy to do, especially with the pressures of research. Bill's here, there's Bill, and this is at the Coorong, and Marcello's windsurfed all the way to Kangaroo Island. He's been all the way across the Gulf, and he's sailed to Sardinia, I remember, a few years ago, and all over the place. But Marcello's primary interest was his thirst for scientific inquiry. And as a medical student, it was pretty early on that he realised he wasn't really interested in dealing with patients. He was more interested in dealing with research and answering questions which hadn't been resolved. And this is an image that Marcello took with his camera down the microscope. Danny was talking about noradrenaline. These are actually noradrenergic neurons in the gut wall. And still we have no idea what they do, but Marcello saw them in the 60s and took a photograph with his camera. He was so excited. Marcello even made fun of his mentor, Jeff Bernstock, who really ignited autonomic neuroscience in Australia. ATP, believe it or not, is not only a neurotransmitter, it does many things, but before that hypothesis was accepted, Marcello made fun of it and many others and said there was macronergic transmission. But really what Marcello was probably most famous for at work was his science and the unravelling the nervous system in the gut wall. And never in history has there been a time where the gut and brain connections have been more exciting to medical science. I cannot believe the field we're in at the moment. It's changing by the second. And a lot of the work that people are referring to and looking back now is by these two gentlemen here. John Finesse used to be the head of anatomy. He's now in the Florey. And Marcello have had an enormous influence on many, many people around the world. And by the way, for those of you who don't know, of the 15 Nobel Prizes in Australia, one of them was to a gentleman from Adelaide, and that was on the gut. It's the only Nobel Prize on the gut. time's ticking away, so I'm going to try and finish 1 minute. I had the privilege of listening to Marcello receive many awards. This was in Amsterdam in 2018, where he received a Lifetime Achievement Award for his work on the gut wall. He's written a number of books, one with Jeff Bernstock, one with over 4,000 or 5,000 citations with John Furness. And Marcello in '88 was elected into a Fellow of the Academy of Australian Scientists, and a few years ago he received an Order of Australia for his services to higher education and medical research in the field of neurophysiology into professional scientific bodies. And whilst Marcello was incredibly active in this research in Australia, also he was at zoology at Melbourne, he was teaching all the time. So the students got to see firsthand research from people making the discoveries, which I think is really important and something that's changing in academia a bit now. In '83, there was a meeting at Flinders, and then we organised one in 2014. That was about a fifth of the people that turned up, but these are some of the world leaders. That gentleman there is actually the CEO of the Mayo Clinic now. He's a good friend we talk to often. He came out, and then we organised the 2020 meeting during COVID, which was not simple. This is Marcello's publications. I just quickly screen grabbed this. His most productive period was in the last 10 to 12 years. And so, as I said before, it's a tremendously exciting time, and we've almost actually generated more questions than answers, I think, now. Okay, I'm going to finish. Jeff Bernstock and Molly Holman started autonomic neuroscience in Australia, and Jeff brought Daniela, it's lovely to see here, and Marcello here. This was actually my PhD supervisor, a lovely lady who was in the 50s, came from Oxford, and I was her last student. So these two really started a lot of Australian science. Simon actually got me to Flinders, and Marcello got Simon to Flinders. So it's a cascade of generations. And so I'm going to just quickly, I know we're out of time. Have I got 1 minute? 1 minute, okay. Simon sent me something to read. This is 60 seconds. I'm so disappointed to miss Marcello's book launch, although luckily I've had a preview. Marcello has written a charming series of reflections of a life lived with passion. He starts with his early childhood in Italy, his move to exotic Buenos Aires, and his later return back to Italy. At university, he's described as an activist committed to principles. He was outspoken with little fear of authority. Some things don't change. However, he redeemed himself by his excellent research and his formidable intellectual rigour. Neuroscience led him to Australia in 1975. He moved to Adelaide to take up a lectureship in this very building. Over the next decades, he led a series of innovative and imaginative studies which made Flinders one of the top places in the world to study the gut. In 1988, his reputation drew me to Adelaide to learn how the magic happened. I never looked back. Marcello provided sharp intellectual insight, practical advice, tough criticism, and above all, generous encouragement. He has and continues to have a huge influence on me. He has also encouraged many others researchers around the world in the intervening decades. Marcello is recognised as one of the international giants in neurogastroenterology. He's had a profound impact on the field and has touched many, many lives. Of course, there isn't time to talk about his commitment to family, his earlier talent as a painter, and his weird delight in climbing steep things, or his ability to pluck a tune from a guitar. You can find all about these in his memoirs. That's what they're for. They're a good read, and I wouldn't hesitate to recommend as an object lesson in how to lead an intense and fulfilled life. So, I'm going to finish with two quotes which I think really summarise a lot of what my experience around Marcello is, that science is not just a body of facts, but a way of thinking critically and objectively about the world around us. And one of my favourites from Einstein, creativity is seeing what others see and thinking what no one else has ever thought. And these are incredibly applicable. We have actual examples of this. So it's been a tremendous honour to be exposed to such talent, and I'm very proud, and you should be very proud of Australia and Flinders, and there's great people here, great experts in their domains. I think as a nation we punch far above our weight, and I'd like to encourage you to have a read of Marcello's book. So thank you very much.
It's pretty hard to follow that, isn't it? I think, though, and it's pretty applicable for our next session, which is a report back from a number of people who had support from the SALHN grant inquiry system, and these, for people who are there, don't feel intimidated by that, just realise that you're beginning a journey, and if you get half of that journey, wouldn't it be fantastic? I'm really pleased that our two chairs for the next session, I just want to speak about them for 1 minute. Simon Windsor and Lauren Perry. You've probably seen them around the place. I hope most of you know them, but I just want to tell you that we wouldn't be here, we wouldn't have had the week without their incredible efforts, energy. It's been fantastic. We've already started talking, this morning we're all exhausted. Thank goodness it's the last day, but what's it going to look like next year? So I'm really pleased that they're here for this session. It's an important one, and I encourage you to not be intimidated, speak up and enjoy what's a pretty special moment for us all. Thanks, Simon.
Thank you very much, Andrew, and thank you everyone for joining us. It's so great to hear from Danny and Bob, and I think, some of the things that may have created an opportunity for your careers, Doug McAvoy and the impact he made. We just heard about Marcello's amazing career. Congratulations. As Andrew said today, the first conference posters in the library with the research hub that we just opened today, and it's Marcello's from 1977. And that's part of the social responsibility of research. So it's about how we recruit participants and work with the community, but it's also about how we share what we've achieved. So that's what today's session's about, the first 2 years of our inquiry grant round recipients. So I'll let Lauren introduce the first speaker.
So first up, we've got Duncan Lodge, who's a physiotherapist here at SALHN, and he is going to talk to us about his project, outpatient redesign involving allied health triage and assessment to support a reduction in neurosurgery waiting lists. So everyone give Duncan a round of applause.
Thanks, Lauren. So I'm Duncan. I'm a physio. I've been working here at SALHN for quite a few years now, mainly in the outpatient area. And I've got a bit of a history of looking at service improvement in terms of trying to get patients in and not having them wait too long. And more recently, this has kind of led me into doing some research. So I'd like to talk to you today about implementing a novel model of care to help get spinal patients off the waiting list for neurosurgery. And to do this, I've obviously had the help of a very good team. Lucky enough to have had the support of Jane Bickford from Flinders University, who's been a mentor for me for the last couple of years and helped me out a hell of a lot because I didn't know much about research. Also, Dr. Emma Knight, who's been supportive of this process from the very start and is always keen to try and help her patients in neurosurgery get in and get the care they need. So what I'd like to do is talk firstly about the research we did a year ago and then talk about what we're doing with the grant inquiry research. So basically, oh, I missed the slide? Yeah, sorry, there we go. So back in 2020, neurosurgery had a pretty bad waiting list, second worst in the state. Some people waiting up to 10 years to get in, which I think we can all agree is not good. So, and most of those referrals were for back and neck pain patients who were probably not going to have surgery. And reducing the waiting list for neurosurgery became a sort of a key thing for SALHN. So with our first bit of research, we've had a sort of a mixed method approach. And we set up a stakeholder group. We interviewed participants. We interviewed and surveyed patients. And they basically told us they weren't very happy waiting years and years. It was very frustrating. They kind of wanted to know whether they can have surgery or not. and their sort of quality of life and health was basically just getting worse and worse, sitting on the waiting list. We had a look at the waiting list data, and we did a cost-effective cost analysis looking at avoidable ED presentations and hospital admissions, and worked out that the waiting list was costing around $116,000 a year. We also did a bit of an evidence review and took that to the stakeholders, and that basically showed that if you had a physio in the spinal surgery, in the spinal clinic, that they could see patients effectively, safely, have strong collaboration or correlation with the surgeons. It helped to reduce the wait lists, and it was cost effective. So we took all that information to the stakeholders and ran a few workshops, and basically through that we worked out a model of care, which is this. So basically in this, the idea was that instead of the neurosurgeons doing the triaging and assessments for spinal patients, that a physio could do this instead, but it was thought best and safest that that was done in the neurosurgery clinic with consultant oversight. And also, just going back to the literature did show that the other physiotherapists that worked in similar models, they felt most supportive if they were actually in with the consultants and the registrars. So from that research, we came up with a plan, developed the model of care, which you've just seen, put a business case in, which about 3 weeks ago now finally got approved. So we're going to have some physios working in the neurosurgery clinic. Hopefully, if we get that all up and running by end of October, early November. Implement the model of care. We've started that before the business case got through in a small way, i.e. me once a week, one morning, and then we can try and evaluate the model of care. So really the aim for this next part of the research is to implement and evaluate the model of care where physios triage and assess the non-urgent spinal patients. And what we're going to do, we are going to survey the consumers. So basically going to ask them just before the appointment what their distress score is for their spinal condition. We're going to find that out after the appointment, and we're going to find out their satisfaction with the appointment and the recommendations. We're also going to try and get satisfaction surveys from the referrers, so from the GPs. That's probably going to be the biggest challenge. We're also going to survey the stakeholders, so the neurosurgeons, nurses, allied health, admin staff that work in the clinics, to see how they find the pressures of us being there in terms of space, time, allocating new appointments, all that sort of stuff as well. We're going to make sure that the physio and the neurosurgeon correlate well when we're triaging. So that's going to be a blinded study of 50 referrals. So I'll be doing the triaging, so I won't know what the neurosurgeon's written, the neurosurgeon won't know what I've written, and someone will compare the two and they don't know who's done what. So hopefully that shows some good correlation. We're also going to look at the health pathways following the consult to see if basically if similar patients are going similar ways for the neurosurgeons and the physios. So are we basically referring for MRIs similar amount to them or less than them maybe? And are we sending on for surgery the same amount or same number of patients? So we're going to check that out basically and try and make sure there is a strong correlation for our service. We're also going to do a little bit of a wait list analysis. So we're hoping to get the wait list down so that people are being seen within a timely fashion, so within what's clinically recommended. So basically for a Cat 2, that's 3 months, and a Cat 3 patient, 12 months. We're also going to do an economic analysis. So we'll have Dr. John Carnan hopefully helping us out with that from Flinders Uni. So we'll try and look at the cost of having the physio, the cost of the implementation of the service, and the cost of the health pathways that we choose, and also compare that with the number of people off the wait list, so that that will help with reduce that ED and hospital admissions. And then we're going to take that all back to the stakeholders that we started with right at the start, show them what's happened, feed that back and see if they have any other recommendations. And these are the successes so far. So we won the grant, we've got the business case approved, we've backfilled against me so I can do the work. I've started a master's in research, somehow managed to get that in between all those other things. We've had ethics approved, we've started recruitment, we've got 20 consumer participants, done about 10 stakeholder surveys, sent out 15 letters to GPs, got none back yet. So we're going to be ringing them in a minute and find out what their scores are and their satisfaction. And I'd like to thank these people as well.
Okay, do we have any questions for Duncan about the program he's deployed? Okay, thank you very much, Duncan. So we go from physiotherapy. Duncan's taken up a new role, an advanced research coordinator as well in his spare time. And now we move to social work. So we've got Ben Riley, family reinforcement and contingency management for gambling, a feasibility and acceptability study. So can everyone give a round of applause for Ben?
Hi, I'm Ben. I've eaten too much pizza. Australians spend a staggering $20+ billion each year on gambling. 3/4 of Australians place a bet at least once a year, with around a third gambling at least once a week. And while approximately 1% of the population will develop a serious gambling addiction, almost half of all Australians that do gamble will experience some level of harm. And while we have high-quality proven treatments available, very few gamblers who develop problems seek help, and when they do, it's typically amid a crisis or after substantial harm is endured. The family and the people around the gambler tend to be well aware of the need for help well before the gambler feels motivated to change. I'm not going to provide a critique of the well-known stages of change model, but merely use it to highlight the point that when you do consider the available interventions on offer for gambling problems, almost all of them assume that the gambler is contemplating change. Even motivational interviewing, for instance, assumes that the person is at least willing to have a conversation about their behaviour. Yet we can reasonably assume that many gamblers with problems fall under pre-contemplation stage. That is, they are not ready to even speak about their heavy gambling, let alone consider seeking help. Meanwhile, gambling help services largely sit passively, waiting for gamblers to motivate themselves. They need to want to change. You can lead a horse to water, but you can't make it drink. You can't make somebody change. Really? There is a mountain of literature in classroom behaviour management that demonstrates how you can influence behaviour indirectly by manipulating the environment. My wife is a junior primary school teacher, and I was reading all these articles when she was doing her Masters of Special Ed. So this is all her fault. I tell her that. Very common approach in the classroom, contingency management. The teacher provides a personally tailored reinforcer to the child when they focus on their task. The more personalised the reinforcer, the greater effect. Stephen loves dinosaurs, particularly from the late Triassic period, and his favourite colour is blue. He attends to his worksheet. So good to see you focus on your worksheet, Stephen. Here's a blue sticker of a Plateosaurus. Simple and very effective. Do you know what's even more effective? When the students' peers provide the reinforcement. So here the whole class is taught the techniques like a game. And so they'll provide a planned reinforcer when the student focuses on their task and withhold it when they go off task. peer reinforcement has a much greater effect on behaviour than if the teacher provides it. These are called unilateral interventions. So what's this all got to do with addiction? The forces of operant conditioning don't suddenly magically stop working when we turn 18, so it's no surprise that similar unilateral approaches have been developed in the areas of substance addiction, the most well-known being the community reinforcement family training approach, or CRAFT. A simpler and more effective approach was developed here at Flinders in the mid-1990s for alcohol problems, and I've drawn a lot from that work too. These approaches have been shown to be effective at assisting families motivate their treatment-refusing loved ones to enter treatment for alcohol, opioid and stimulant addictions, but to date they have not been effective for families of heavy gamblers, despite no fewer than 4 attempts. So, why has it not worked in the context of gambling? I think there is a flaw in the assumption that what works for substance use disorders will also work for gambling, a behavioural addiction. Are there important differences that should be considered, particularly if we want to use the principles of operant conditioning? My PhD, which was finished mid-last year, largely focused on exploring these questions and got me to a point where I had some solid answers and was ready to use this knowledge to develop an intervention for families of unadmitted heavy gamblers. I just needed some time and funding to do it. So I'm very grateful to have received a grant through the last year's inquiry grant round. So using the knowledge developed from my thesis, I've spent a large part of this year developing this. We now have a nice looking workbook that's considered of 5 graded sets of responses for the family that are designed to gradually increase motivation for the gambler to change. And I'm grateful for our SALHN Media and Comms team who've helped me put this together. So we've called it Family Reinforcement and Contingency Management for Gambling, or FRCM. We tried to put sort of vowels in to try and make an acronym. We put like family and contingency. We got FARCOM. So we left it. So we're sometimes told to watch our P's and Q's, but I think vowels can be just as dangerous. And the GAM refers to both gambling and video gaming. So we've also adapted this for use of video gaming addictions, which is another problem where the family tend to develop concern long before the gamer is ready to seek help willingly. So the title Family Reinforcement Contingency Manager is also a bit of a throwback recognition of the original work in this area of Solomon and Skinner. We've, as I mentioned, we've adapted it for video gaming addiction, and we've used it successfully with several families. The first one, we published a case report, which we believe is the first time this approach has been used, has been reported for video gaming addiction. As you can see, I'm a bit of a gamer, avid gamer myself. I'm into the headset VR gaming, which is amazing. You're not chasing a little Jedi around the screen on a flat screen. You are a Jedi. You are an actual Jedi. I'm set lightsaber. You've got hand tracking. You can use the Force. I got my I got my Jedi Master stripes recently. So. Here's my 3 PhD supervisors who helped me get this work to this point: Sharon and Malcolm from Flinders and Beth from Deakin. Beth was originally involved here in Flinders in the 90s in that alcohol study I showed you earlier on, so it was great to get her on board. So now we're testing the intervention. Just this week begun recruitment. So we're doing an RCT to test the feasibility. I'm going to skip a little bit forward. So 3 main objectives, the main one being to motivate the gambler to seek help. We've registered the trial. We're going to randomise 30 participants to the intervention group or the treatment as usual group. To recruit, we're using a targeted social media campaign. Thanks again to our social media and comms team for working with me on this. So essentially, we'll be comparing the newly developed intervention with standard care. So standard care focuses on the well-being of the family member, where the intervention is focusing on helping the family member motivate the gambler into treatment. And we want to see essentially how many from each group enter into treatment. A number of other measures as well, stress, anxiety. And we're going to do a qualitative component at the end of it too, to examine more of the acceptability part of it. So that's it. Thanks again to the SALHN Inquiry Grant Scheme and Flinders Foundation for supporting this, or supporting all these projects. You know, it's really challenging as a health clinician working full-time in health to do research, and schemes like this help to make it possible. So thank you.
Thanks, Ben. Does anyone have any questions? No? Move on, and I'll ask Dr. Leah Moffat to join us. She is going to present on the assessment of blinding for nerve catheter study.
Good afternoon, everyone. Hi, my name's Leah. I'm one of the RMOs here at Flinders. I'm part of a group from the anaesthetic department led by Adam Badenoch, who's been looking at the assessment of blinding in nerve catheters. Just check this. So blinding is an important part of clinical research to ensure that we reduce any potential bias in our study. It is particularly important when we're looking at subjective outcomes. It's something that is not often assessed, and when it is assessed, we do it quite badly. So that's why we decided to investigate this. And when we have a lack of blinding, that can lead to an overestimation of our treatment effect. So it can have an important significance. So for nerve catheters, they are a small, thin plastic tubing that are inserted near a nerve to provide analgesia. Local anaesthetic is delivered through that catheter, and often they're used perioperatively, such as for amputations or around abdominal or gynecological surgery or for thoracic trauma. When we assess nerve catheter use in clinical trials, the control method is usually with a sham catheter. It's inserted in exactly the same way as you would a normal nerve catheter, but instead of delivering local anaesthetic, you then deliver saline, and that brings some ethical risks because it has all of the risks of inserting a nerve catheter, such as any damage to nerves, blood vessels or organs, but absolutely no potential for any benefit because you're not going to be delivering any analgesia, it's just saline. So they're an invasive method, and we've designed a novel technique to try and avoid the use of sham catheters. So I'll just talk you through how our technique works. So if we start with the drug reservoir there, we've got 0.2% ropivacaine, and that's delivered through a pump, and we deliver that by pressing a button, and then 10 mils of the local anaesthetic is delivered through the system. It meets a three-way tap, and then that can either be set to the experimental or the control mode. So it can either go into the mannequin, which is the experimental mode, or into the blinded reservoir, which is the control mode. So looking at it in real life, this is what it looks like. So we've got a pump on the right here. It goes through the yellow-coloured tubing, meets our three-way tap, and then either goes into the mannequin or our reservoir here into this bottle, which we had placed in an opaque box to try and disguise which way things were going. We also put some tubing around covering around the tubing to try and minimise any signs, bubbles or movement of the tubing, to try and disguise which way we had set the setup. There's a closer look at the three-way tap. So we randomised this using a computer-generated randomiser in blocks of 80 to see which way it was set. I think it maybe has a low battery. Is there a charging cable? Should I continue on? That's all right. I'll put on. I could present it blindly, but that's probably not a good idea.
It's rebooting now. Okay.
Be a minute. Does she go? It's still battery. Yeah, I think so. Oh, there we go. It's not Does she know where it's connected to? Sorry. Yeah, it's good. Yeah.
rheumatic arthritis. So I found coming into that session was really quite insightful because that's been a very recent diagnosis and something quite close to my heart. So it was wonderful to see Dr. Mejia come up and speak. Does anybody else have a favourite session? How about you, Simon?
Julie Wagner, I loved that one around the precinct. That was fantastic.
That was a wonderful session. And Dr. Kate Laver, Professor Kate Laver, I did very much enjoy her session as well. Kerry, I know you were very under the weather, but did you have a favourite session?
I was probably pretty thought-provoking, as I said earlier today, from the Chalmers oration yesterday. That's given me a lot to think about.
We're very fortunate here at SALHN to have such a wonderful week-long celebration of research.
Can you just go grab one for Danny?
I'm quite new to research. I'm a nurse from Alpha Flora and I've got a specialist interest in wound care, but research is something that's been very new to me. I've only just joined the Office for Research team in March of this year and have been very lucky to be welcomed by such a wonderful and exciting team led by Simon and Professor Andrew Burston. I don't think I've ever worked with such a supportive and wonderful team that I am now. It's been very exciting. Simon and I have had a couple of trips over to Melbourne where we've spoken with Alfred Health and Monash Health, and we've also just recently got back from a conference for the VCCC Cancer Alliance where we were able to present a poster. So that's been very exciting for me in my own professional career. So again, I'll ask, does anybody have a particular favourite session that they've seen? No one. I'm so sad. They must all be wonderful. Yes?
The child protection one by Daryl Higgins.
Yeah, that was brilliant, wasn't it?
It was brilliant, and I would actually recommend anyone who has anything to do with adult patients to actually watch the video, because it actually it will show you that probably 60% of your clients have had some form of child protection issues in their lives, and therefore need a very different way of working with them. So I think it was a very good session.
It was a very good session, and as you said, if everybody could log on and have a look online at the sessions that have been recorded, that was a particularly good one as well. So I know that next week we'll be launching a survey, and that'll be asking you what you thought of this year's Research Week and what you'd like to see in next year's Research Week as well. So that'll be very exciting to hear everybody's responses of what they've enjoyed, and again, what they'd like to see for future research weeks. So I don't think that we have our technical difficulties fixed just yet.
So almost there, yeah.
Almost there. So I'd like to thank everybody for coming. It's been absolutely wonderful to see so many faces in the crowd and so many online as well. It's been a really exciting week, and I hope you can all stay for the end of today's session. So thanks for coming.
It's okay with everyone if we're just going to break quickly now for afternoon tea, just while we get our technology sorted, and then we'll come back and we'll finish off the rest of the inquiry, grant presentations, and then go to our next session. So thank you everyone so much for your patience, and we'll see you back here in half an hour. Okay. Thank you everyone for having an early break, and I apologise again to Leah for that interruption, but our tech issues are resolved and we are good to go again. So I look forward to introducing Leah again to talk about the assessment of blinding for nerve catheters.
Great. I might just get back to close to where I was before. So just emphasising that, that we have two options that the route of the anaesthetic can take, either into the control option, which is a reservoir, or into the mannequin, which is our experimental mode. And the thing that changes this is our three-way tap. We used we randomised this in groups of 80, to achieve our sample size of 480, and then that was set either the experimental or control mode, and then we sealed the box and taped it up. And then we've also, this is our design that we 3D printed the box from. We can also pop some cable ties in there to minimise any tampering with the box. So we took our mannequin around the hospital to recruit 481, I think it was, participants. We went through outpatient clinics as well as around the wards and around intern teaching and in PACU to try and get a good distribution of patients, family members, doctors and nurses to get their opinions on which way they thought the fluid was running. And we gave people 15 minutes to observe the bolus running through, and they were able to have a look and feel and touch everything to help come to their decision. And then at the end of that 15 minutes, we asked them which way they thought the fluid was running and why. And then if we offered them a don't know option, if they weren't able to tell, and then we, after that, the people that said they didn't know, we forced them to make a choice so we can get a bit more data. So just to clarify, the control option here, the nerve catheter doesn't pierce the skin. This is the non-invasive aspect of it, so it just sits on top there, and then we covered it up with a dressing so that it was difficult to tell between the experimental and control modes. But that's really the kind of crux, is that it's a non-invasive option for the control. So when it comes to analysing the results in blinding, it can be a bit difficult because there's multiple ways that the data can be distributed to show perfect blinding. So if we consider an experiment of 100 people and half of the time it's set to the experimental and half to the control mode, we could achieve perfect blinding by having an even distribution between people guessing experimental and control, and there's no significant difference there, and 0 people saying don't know, or in an alternative setting of people saying, like the complete people saying that they don't know, and that's still achieving perfect blinding. So it makes it a little bit difficult, because if we put those results through like a normal chi-square analysis, it would come up with a very significant p-value between the control and the experimental, which is not the case because we have achieved perfect blinding in this example. So that's why we used a blinding index to try and demonstrate, and a blinding index of 0 would be a situation with perfect blinding, such as this one. So looking at our results, so we got our 481 participants recruited last year, and then we broke them down into doctors, nurses, patients and other, which were other allied health staff, family members and visitors, and students. And then we looked at the correct responses in those subgroups there. And I'll just have a look here. So, and then in our further data, we looked at the experimental and control mode and broke that down to how we got our correct options, and then our correct response rate on that right-hand side there overall was 55.3%. So when we look at the blinding index to see how well we were able to blind people, looking at this graph here, we have a positive blinding index on the right-hand side. We've got people that are able to correctly identify the setting and then correctly guess. So, and on the other side is reverse guessing. So that would be people that, beyond what we'd be expecting from just chance alone, would be able to identify the correct setting but then choose the incorrect setting intentionally, which would be a very unlikely scenario, but not impossible. So we still allowed two-sided hypothesis testing in our analysis. So overall, we can see we had, between the control and the experimental mode, a mean blinding index of 3.75%. So we can safely say that we blinded 96% of our participants, which was quite good. So then on to our reasons why people came to their decisions. And we looked at if any of those led to people having a high correct response rate. So most of them, people saying that they could feel or see things that led to their decision, were not very significant in causing a correct response rate, apart from the one which was the pump alarm or the kinking of the tubing. So 14 people were able to kink the tubing and then deduce, because that led to a downstream pump alarm from the pump, they were able to deduce which way the three-way tap was set, and that led to a 90% correct response rate, so quite a significant method of unblinding there. We also wanted to make sure that having the don't know option in our questionnaire didn't influence our data set. So once we forced people to make a decision after they didn't know, and then we collated all of that data, we still received a similar correct response rate to that 55.3% at the end. So not a significant difference having that don't know option there. And that's also imaged here on our blinding index graph. We also asked in our questionnaire about any ethical concerns that our participants had about having such a setup used in future on humans. So 85% of people didn't have any concerns voiced about ethics. And then when we look further at some of these topics of ethical concerns, I just have some examples here that you can have a bit of a read through. We found that on the whole, almost all of these were non-issues when it comes to ethics. So in terms of limitations of our study, while the control mode is non-invasive and doesn't pierce the skin, the experimental mode still has to be inserted as a nerve catheter usually would, and that would lead to a really obvious source of unblinding if you're having a nerve catheter placed under the skin. So that's why we would only be able to apply this type of research into studies where there's a period of time where the patient is adequately anaesthetised, so they would not be able to understand or recall if they've had any nerve catheter placed under their skin or not. So in conclusion, we've been able to successfully blind 96% of our participants, and we believe that this is a setup that could be used in the future in human clinical trials, as long as there is a period of time where the patient is adequately anaesthetised for the nerve catheter to be inserted. And by achieving this successful blinding, we are able to reduce bias and avoid the use of any harmful invasive sham catheters in the future of research. And then we suggest that to improve the device, we could come up with a way to prevent any deliberate kinking of the tubing, which was one of our greatest source of unblinding. And the SALHN biomedical engineers have actually done this for us. So they've provided some tubing that is not kinkable, and then also have come up with a slightly different setup that avoids the use of the three-way tap, so that if you were to kink the tubing anywhere across the setup, that it would alarm anyway, so that that kind of negates our main weakness of the study for unblinding. And I'd just like to close by thanking the Hospital Research Foundation and the Flinders Foundation for support with our inquiry grant, Rick Fronzo for building our model, and then also the SALHN biomedical engineers, particularly Lianyu Yang, for providing the additional changes at the end for further improvement of our model. Thank you very much.
Thank you so much, Lee, and a great collaboration there with Biomed as well for that work. So do we have any questions?
I promised Lee I'd come up and help with questions, especially some of the stats bits if needed. But yeah, Biomed came knocking on our doors. I think they might have got an information leak from you or someone after we got our grant. It was great to have them knocking on our doors.
Award ceremony, maybe we had the award ceremony on 22nd of March. So that's excellent. Great collaboration. Thank you so much. Okay, thank you very much for that, Lee and Adam. So we move on to anaesthesia again, which is really exciting. They're very prolific researchers there, and now we're with their research director, Dr. Fiona Taverner, who's presenting on baby chicks, the caudal high flow oxygen and dexamethamine sedation in interguinal hernia surgery in neonates and infants, a feasibility study. Thank you.
Thanks very much. So what's the problem? Worldwide, 10% of babies are born preterm. Inguinal hernia surgery is the most common operation performed in neonates in infants, both in Australia and New Zealand and in the world. What are risk factors for development of inguinal hernia? Being born preterm, being born of a low birth weight, requiring mechanical ventilation, and unfortunately for them, being a boy. What do we know already? We know that if you're a neonate or then an infant, your perioperative mortality is higher than other paediatric age populations. We do know that if you're an infant or a neonate and you require an anaesthetic for an operation, you have a critical event rate that approaches 35%. A critical event being something that, if it was left untreated, would result in significant morbidity or mortality. We know that if you're an infant and you have a general anaesthetic for your inguinal hernia surgery, you have a significant likelihood of being intubated post-operatively. Depends which paper you look at exactly, but most of them put you at around 8 or 9% likelihood of being intubated post-operatively. We know that before we started this study, if you had an infant that had a general anaesthetic at Flinders Medical Centre, the likelihood of them being intubated postoperatively was actually 22%. And we know that regardless of your type of anaesthetic, whether it was a spinal or a general anaesthetic, the risk of having a perioperative complication was somewhere between 55 and 65%. I'm actually kind of embarrassed to tell you these statistics, but I thought it was really important to provide a context for later on in the talk. And I probably should mention that it was, I didn't do the audit until after I'd thought about doing this next feasibility study, but it was kind of this, these situations or scenarios that were occurring that actually led to this feasibility study and all the other work that I'm doing at the moment. So Baby Chicks is a feasibility study of an anaesthetic technique that is not routinely performed in Australia and New Zealand, and in its exact iteration is probably not performed anywhere in the world. It's a multi-centre feasibility study and we aim to recruit 50 patients. It's an opt-in study where for the surgeon and the anaesthetist, so they can opt out if they didn't want to be involved. Parents were required to give consent. And anaesthetists, because of our ethics approval, were not trained on the technique before we started the study. So they had a flow chart that they could follow, and PIs were available for assistance but have not been in theatre for every case. So what actually is a Baby Chicks anaesthetic? It's delivering high-flow nasal oxygen with a blender. It was designed, a modified device by Fisher and Paykel. The blender is really important because it allows delivering the exact amount of oxygen that's required to titrate to an infant's target saturations, oxygen saturations, because these infants are likely to have chronic lung disease or retinopathy of prematurity, so giving too much oxygen is actually toxic for them. Dexmedetomidine delivered intravenously for sedation, the goal being to provide an immobile sleeping baby but preserve hemodynamics and spontaneous ventilation. And a caudal anaesthetic, so injection of local anaesthetic into the caudal space, which is continuous with the epidural space. So in essence, what you're doing is a single shot baby epidural. And just to give you an idea of what it actually looks like, he's a little boy having his inguinal hernia repaired. You can see that he's completely pain-free having his operation. This is a real photo. He's completely pain-free because of his caudal. He's sleeping peacefully with the assistance of his dexmedetomidine sedation provided intravenously, and his breathing's being supported with his high-flow nasal oxygen there. And you can see that he's actually still sucking on his dummy while he's having his operation. So in this feasibility study, we recruited any infant that was having an inguinal hernia repair under 64 weeks post-menstrual age. And we excluded basically only babies that had a contraindication to a specific aspect of the technique, and we haven't found any of them so far. So this is a flow chart that the anaesthetists were provided to assist them with the run-through of how to do the anaesthetic. I would mention that each of the individual components of this anaesthetic technique are not unfamiliar to anaesthetists, but putting them together in the specific combination is unfamiliar to the anaesthetists and the surgeons. We also had a flow chart for suggested management of intraoperative complications and routine measurements specifically looking at perioperative complications. So the primary outcome for this study is actually just, can you use this anaesthetic technique to safely, or to actually just complete the surgery without converting the baby to a general anaesthetic, and secondary outcomes focus on perioperative safety data. So I'm presenting to you today the interim analysis of 30 patients. I was hoping to provide final results, but we've got 2 babies left to recruit, so we're nearly there. So in this study, we've done the technique at Flinders Medical Centre, Women's and Children's Hospital and Christchurch Hospital in New Zealand. You'll note that only one of these hospitals is a tertiary paediatric hospital, and 2 of them are mixed adult and paediatric centres that both have neonatal intensive care units. So for these 30 babies, we've had 11 different anaesthetists and 6 different surgeons. So who are the babies that we've had so far? Almost all of them have been boys, unsurprisingly, with a mean gestational age of nearly 35 weeks. Birth weight mean was 2.2 kilos and weight on the day of surgery was 4.1 kilos, so still relatively small babies. So just over half of them were born preterm with a variety of comorbidities, and about 40% had both sides operated on, and the others were single-sided hernia repairs. So I'm really pleased to report that so far we've got an 80% success rate for completing the surgery with the baby chicks anaesthetic technique without converting to general anaesthesia. Of those that did require conversion to general anaesthesia, there was a variety of reasons, but most of them were essentially inadequate anaesthesia or pain relief at the time of knife to skin. I don't know for sure, but I suspect that this number may drop as anaesthetists and surgeons become more familiar with the technique. So with the anaesthetic and surgical data, the most interesting part of this to me is that while the median surgical time was 34.5 minutes for those babies that successfully completed the baby chicks protocol, 5 babies had a surgical time that was greater than 55 minutes, and 1 baby had a surgical time of 93 minutes. So to me, this suggests, doesn't necessarily prove, but suggests that this anaesthetic technique means it's possible to do longer, more complicated operations with this technique rather than them requiring a general anaesthetic. When we look at intraoperative complications, you'll see that these are remarkably low. And post-operatively, again, looking at apnea, bradycardia, hypotension, desaturation, remarkably low. The most common complication was just requiring an increased level of oxygen or respiratory support in the first 24 hours post-operatively. And I think that 20% is still pretty acceptable given the cohort of patients. And I'm really proud to report that we've had no babies intubated post-operatively, either in this group of 30 babies or in the 48 babies that we've actually recruited so far into the study. So in conclusion, so far we've got an 80% success rate for completing the surgery successfully, and early data suggests it's possible for longer, more complicated hernia repairs. And it's possible in different hospitals with different surgical and anaesthetic teams. So this is not a one hospital, one anaesthetist, one surgeon technique. We think it's probably safe with an acceptable complication rate and no significant adverse events so far, and that we think that with experience and training that the success rates will likely be higher. But there's a lot of people that have been involved that I'd like to thank, but specifically the SALHN inquiry grants with the Flinders Foundation and the Hospital Research Foundation group. Thank you.
Are there any questions? Thank you. That was fantastic. So next up, we have Dr. Tamina Levy, who's going to talk to us about co-designing a toolkit to promote recovery after stroke. Thank you.
Hi everybody, I'm Tam, I'm a physio working over in RAP. I'm going to talk to you today about the Adherence Counselling Toolkit study. I need to say, first of all, I'm a bit remiss in I didn't have an acknowledgement slide, which is terrible, so I'd like to acknowledge the SALHN research grant. I'm very grateful that I've been able to progress the research, and I'd also like to acknowledge my team. I feel terrible about that. Professor Lucy Lewis, Dr. Elizabeth Lynch from Flinders Uni, a consumer researcher, Saran Chamberlain, and some allied health staff from RAP, Nadia, Kelly and Emily. And I'll get started. So this study was important because way back in 2003, the World Health Organization did this great big project on adherence to long-term therapies. And in that they said that increasing the effectiveness of adherence to interventions may actually have a greater impact on population health than for the specific treatments themselves. They also made this recommendation that we develop adherence counselling toolkits to help health professionals help people with chronic conditions. We know that many people with stroke struggle with adhering to our physical activity and exercise recommendations, and I know that from my PhD studies as well as lots of other really high quality research. And there are no adherence-focused toolkits as of yet, and this was confirmed in a systematic review we've done, which is currently under review. So this is a talk about physical activity adherence, so I think I'm going to ask you all to get up and do some exercise. So, everyone standing up. Arms out in front, doing some squats. So now, I just want you to imagine you've had a stroke, and as you're doing that, your arm is painful, it's really hard to lift up. As well as that, your foot's curling underneath you, and you feel balanced, and you're actually really scared you're going to fall over. You also actually don't really see the point. You don't get it, you don't believe that it's going to help you, and you're so fatigued that you actually describe it as bombed. So these are many of the barriers that stroke survivors face. So it isn't a one-size-fits-all. It's really important we tailor our programs. You can stop now. It's really important we tailor our programs, and that's where this toolkit is going to help. I won't do any more exercise, I promise. So the aims of this research were to explore behaviours of people with stroke and also explore the behaviours of the health practitioners in terms of how they went about prescribing exercise programs to the people they were working with. And then, of course, to develop a co-design toolkit as part of aim 2. So it's really about supporting the health professional to support the stroke survivor. So we had two stages. So in stage 1, we did some surveys. So we did online and paper-based surveys, and that was to health professionals, stroke survivors, carers, and also health managers. And the analysis of those surveys really informed the next stage of the research. So stage 2 of the research, we did some focus groups, and we used a theoretical framework, the theoretical domains framework and the COMBI model, to give some solid theoretical basis to that analysis. We then had a team of experts come together, and that was our stakeholder working group. And we presented them with the focus group findings, and then we also gave them examples of other health-based toolkits from the literature. And then we had the stakeholder group, and that was really more about talking about what the toolkit should look like as far as design and format. And then we're currently at the toolkit development stage. So we're working with a socially inclusive designer called Blend Creative, and we have this constant co-design process. So the research team sending stuff off to Blend Creative, getting co-design consultation with the expert group, and that cycle's continuing. So what have we found? Well, we had 164 of survey responses, which is pretty good. And we found various data around exercise behaviour, strategies. I'm just going to show a couple of things around barriers because we don't have a lot of time. So this was in relation to the health professional barrier. So the darker blue is a stronger barrier. And as you would expect, the main barrier health professionals reported in being able to sit down and spend time with their patients and work out an individually tailored program was lack of time. And then another one was also the actual stroke survivor capability. In terms of barriers perceived by the stroke survivor in terms of adhering to programs, the biggest one was reduced capability. And that's really interesting. So, and I found that in one of my previous PhD studies, even though we're spending time and we're sort of delivering these programs, which we are tailoring, often stroke survivors will say, it's actually just too hard, I can't do it, so therefore I don't want to. And the findings from this stage informed the stage 2 focus group guide. So we had 7 focus groups with 29 participants, and then we had this one stakeholder working group, which is still the group that's doing the co-design aspect and ongoing consultation. As I said, we used a theoretical framework to give some strength to this research. So we used the theoretical domains framework and the COMBI model. So the COMBI model sits in the middle of the behaviour change wheel, which is what you can see on the screen. That says for any of our behaviour to change, capability, opportunity and motivation are the key factors. And then that links with the TDF, which has 14 domains. So we just use this as our way to analyse our data. So we found 5 main themes from the focus groups. I'm going to just show you what they were and just report one example from each of them. So in relation to key issues, a key enabler, that there should be a rehab plan, which is what the stroke survivor wants, not just what the health professional is saying. And that was a physical opportunity aspect with the TDF domain of environmental context. And that's a quote from a stroke survivor. So they're really saying, you know, it should come from us. It should be driven by us. And then in terms of barriers, it was identified that one of the examples is that the knowledge of the staff. So that would be something to consider in the toolkit. What could help promote adherence? So having targets. So a lot of stroke survivors will respond really well if they've got a goal, specific goals. So that was something that was identified. skills and knowledge required by the health professional. So active listening, that people talked a lot about, being able to use a motivational interviewing approach to really really listen and help the stroke survivors reflect themselves as well. And then one of the things that was suggested to be included in the toolkit was information about neuroplasticity. So, as I said, we sort of summarised the focus groups, and we provided the stakeholder working group with a summary of that, plus some example toolkits. And the stakeholder working group was really about what does the toolkit look like, what should be in it, and we talked about, what was essential, what was good to include, but also what should we avoid. And we did that, so I'm just going to, again, report on one of those because of lack of time. So in terms of content, some of the things that were considered essential, physical activity recommendations, how to achieve, tips for motivation, how to bring a family member in, having an action plan, good to include, how to make exercise fun. We know that rehab is not fun. We hear it all the time, and whatever we can do to engage people is really important. So those are some of the things that were good to include, and what to avoid, being too long. Again, that's around that barrier around health professional time. So we need a quick version of whatever it is. So far, what this research has done is show us that there's key factors influencing adherence, and also key barriers impacting the health professionals' capacity to develop and deliver tailored programs for the stroke survivor. The toolkit was very strongly welcomed by all the participants, and they also gave us ideas around what should be in it. So where we're at now is, as I said, we're well into the development of the toolkit phase. It's really exciting. There's going to be a paper-based and an online-based version, and we're planning for some pilot testing. So once the toolkit's ready, planning to do a type 2 hybrid implementation effectiveness trial. If you were here on Tuesday, you would have heard Professor Jill Harvey talk about that. And I have applied for a Flinders Foundation grant, so fingers crossed. I'm just going to finish by sharing a couple of screenshots of the toolkit, the first draft of the toolkit. I feel like I'm sharing photos of my fourth child because I know it very well and I love it a lot most of the time. So this was the first draft. There's been suggestions made. These are some of the screenshots from the first draft. So you can see the sort of stuff that's going to be in it. And that's all. Thank you. Sorry about the squats.
Thank you so much for getting everyone's heart rate going. Really appreciate that. Thank you so much, Tamina. And the final talk, apologies everyone, we're running slightly late, but now we've gone through a whole range of disciplines. Now we've got research scientist from our pain group, Amelia Searle. And she has using cognitive behavioural therapy for insomnia to improve sleep, pain and quality of life for individuals with chronic pain. Thank you very much.
Thanks, Simon. Oh, here's the little clicker. Okay, so I'm presenting on behalf of our research team. We've got clinicians and researchers in sleep and pain across 2 universities, the SALHN Pain Unit and our consumer representative, Anita, as well. And thanks to the SALHN Inquiry Grant Scheme for funding the research. Okay, so sleep disturbance is one of the most chronic complaints among individuals with chronic pain. Sleep disturbance in the context of chronic pain is associated with more intense and longer lasting pain. It's associated with worse depression and anxiety problems and also poorer physical functioning. But cognitive behavioural therapy for insomnia, or CBTI, is the gold standard treatment for insomnia. It involves modifying people's unhelpful cognitions and behaviours in relation to sleep disturbance. And there is RCT evidence showing that CBTI does result in improvements in sleep, but also in pain and depression in people with comorbid sleep disturbance and chronic pain. So this is promising, but what we don't know is how this necessarily works within a tertiary setting. In our tertiary pain unit, in SALHN, and I think this is common Australia-wide, sleep disturbance is primarily treated with drugs or sleep hygiene at best. It's certainly not our area of expertise. CBTI expertise is really not widely available, as you would have heard earlier on in the presentations. So yes, what we don't know is how applicable this is going to be in a tertiary pain unit. Converting this RCT evidence into an effective real-world intervention is potentially going to be complicated by additional patient complexities and comorbidities that aren't always in RCTs. And rigorous research protocols don't always work in a busy tertiary clinic. So with this in mind, what we wanted to know was, does group-based CBTI, is it effective in improving sleep, pain and quality of life, but also is it feasible to run within our tertiary pain clinic and our particular pain cohort? Really, this is very much a pilot trial to determine, if and how this is going to be sustainable within our clinical practice. Okay. So we're currently recruiting people attending their first medical appointment at the pain unit. We're having 4 CBTI groups running, currently got one running from September all the way through till April next year, and we're aiming for about 7 to 9 participants per group, slightly larger than your usual group sizes, but we were sort of trying to factor in attrition. We have the pain unit doctors identifying eligible and interested patients and referring them to the research team. Essentially, the patients had to have chronic pain and sleep disturbance, with a few exclusions. They weren't able to be doing any of our pain unit allied health treatments in case of any sort of treatment crossover. They needed to have stable mental health, not be actively suicidal, and not needing an interpreter for the group format. We were really trying to be as inclusive as possible, given we do have a complex clinical cohort. Really, the best we could do without excluding everybody was just to document any additional medical information. And currently, for the September group that's running, we had recruited 7 participants, and actually it's 8 participants we've got recruited for November now. So we're in the process of recruiting for our 3rd group in February. So the CBTI treatment, it consists of 1-hourly sessions. They go once a week for 6 weeks, and they're facilitated by 2 wonderful CBTI-trained psychologists from Flinders Uni and FIMRI Sleep Health. This is Claire Dunbar and Dara Benson-Boakes. The CBTI protocol, as you can see with the little GIF, it includes elements of sleep hygiene, also stimulus control, bedtime restriction, relaxation and cognitive therapy. But our therapists are using a protocol that has been modified specifically for people with comorbid chronic pain. So what this involves, the sleep restriction component is a lot gentler on people. Also, people don't have to be getting up and out of bed when they can't sleep in the night as part of their stimulus control. And the daytime activity is very carefully implemented through activity pacing to avoid any kind of boom or bust patterns that tend to happen with chronic pain patients. The therapists are tailoring all of this information and strategies to each participant's particular sleep and pain situation. It's taken home and done as homework, and then the therapy progress is then monitored through the homework completion, through our sleep measures that we're collecting throughout, and then the therapy is adjusted accordingly. Okay, so our research outcomes, it's the standard pre-post design. We're collecting measures pre-therapy at the end of CBTI treatment and then 3 months later as a short-term follow-up. We've got online questionnaires which can be done on mobile phones as well. These are assessing insomnia symptoms, pain severity and interference and quality of life. And we do have a number of sleep measures as well, the more objective measures using the wrist-based actigraphy devices and the sleep diaries as well. And we are assessing a number of feasibility measures, again, to really inform how sustainable this is ongoing around recruitment, retention, dropout rates, reasons for non-attendance and dropout, self-reported barriers to attendance, and also participant satisfaction and adherence to the protocol as well. Okay, now as this study, as I said, it's very much about making CBTI work for our patients. So we've already been tailoring our approach to make sure this is something that works in our pain unit based on very early insights. So our consumer representative, Anita, she co-facilitates chronic pain support groups. She took our idea to her consumers, our treatment idea and our recruitment approach, they did have a number of reservations and concerns, which you can see on the screen. So as a part of our recruitment pitch to our patients, we wanted to be incredibly clear that sleep was able to be treated either before or even at the same time as pain, that patients didn't have to be waiting to treat their pain first. And of course, in doing this, they were going to keep their place in the queue for any additional pain treatments. They weren't going to be missing out. And we were very clear that the therapy was very much based on their own individual sleep data coming from those sleep diaries and wrist actigraphy monitors. So it very much was tailored to them. And it became increasingly apparent that our cohort, given their age, BMI, comorbidities, they were at high risk of sleep apnea, which is an important consideration you may have heard earlier for CBTI, given that people with sleep apnea do tend to be excessively sleepy during the day. CBTI can make this sleepiness worse and at potentially concerning levels. And for this reason, some RCTs don't bother including these types of people, but certainly CBTI can be done with sleep apnea patients. It just needs additional considerations. So with that in mind, we put in an 11th hour ethics amendment, which was approved so promptly. We started doing some additional screening at recruitment. We did additional monitoring during the therapy itself, so we're better able to understand people's sleepiness using the Epworth Sleepiness Scale, and we're using those Withings sleep tracking mats that go under mattresses, so we can keep an eye on people's breathing difficulties as well during the therapy. And therapists, this is something that can be, and as we said, it's very individualised and tailored to participants. So if and when needed, the therapists either reduce or they remove entirely the sleep restriction component from the therapy. So in doing this, this is a way of making sure our therapy is, accessible but also relevant and safe for our population. Now, a big part of what we were doing was, again, looking at response and looking at people's barriers in the hope that we might be able to address and remove some of those barriers in future. So far, everything's been going really positive, touch wood. We've had 55% of those approached by doctors saying yes to being contacted. And far and away, the biggest barrier was just distance. People living on the Limestone Coast or Fleurieu Peninsula, although they were very interested, just weren't willing or able to travel, understandably. And again, far and away, the biggest ineligibility reason was just having no sleep issues. We did have a couple of other reasons, and of those actually telephoned, we had 65% recruited so far, with the biggest barriers mostly being around coordinating other work or medical commitments. And indeed, 2 of our participants who we have recruited, who've now been deferred to a later group in November, had a number of their medical appointments clashing with the sleep treatment. So although they were very keen, they did have to rearrange things a little bit. And I think this is going to be a common theme going forward. So we're 2 weeks into group 1, and I don't want to be sort of making too much of this. It's very early days, but we do have been able to learn some good lessons already just from these first 2 weeks. As you can see, the 7 patients we did recruit into the first group, their profile is very characteristic of, moderate to severe comorbid chronic illness, but this is very indicative of patients at the pain unit as a whole. This looks quite familiar to us, I guess. Now, we have had one person drop out so far, but again, because of her complex presentation, I guess, her other medical issues were kind of conflicting with the goals of the sleep therapy, I guess, so it just wasn't the right time for her to be focusing on sleep. But the five who have remained have attended both sessions. They've gone through bedtime restriction therapy. All of them have been able to undertake that. And at the second session on Wednesday, the majority of them had already shown some clinically significant improvement in their sleep issues, not only in their measures, but in, self-reports. We had some patients say to us, "Oh, look, I haven't slept like this in years," and "Oh, look, I didn't think it was going to work this quickly." So, I'm not I'm certainly not trying to put undue emphasis on 2 weeks into the therapy for 5 people, but what I'm getting at is it's a promising response, and hopefully these kind of early indications to the patients will actually be able to keep them engaged for the whole 6 weeks of the treatment. I think by and large, the most difficult challenge will be getting the sleep diaries completed, because so much information needs to go onto them, and it really does inform the therapy. So moving forward, we'll just have to see how we can facilitate the completion. Yeah, not too much to conclude other than from the response so far, it's a fairly safe bet that our patients do value sleep treatment. It's just whether this is the right time in their life for them to be undertaking it alongside all their other medical issues and commitments. But even if it is effective, ongoing, we have to decide whether the greater degree of tailoring and individualisation is going to be feasible for our pain unit, and exactly where we would fit it into the model of care as well around our existing allied health treatments. So yeah, thanks for listening, and watch this space.
Just in the interest of time, I might hold questions for now, but I'm sure any of our researchers today would be happy for you to contact them after if you've got any questions. I just want to thank you all. I want to thank all our presenters today. Their research is so fantastic, and it's great to hear an update on it all. I want to thank the Flinders Foundation and the Hospital Research Foundation for funding these projects and the inquiry grant rounds. We couldn't do it without your support. I think the presentations today and really all of our inquiry grant rounds are really testament to the outcomes you get when you invest in clinician-led research. So thank you again. And I'd now like to introduce Associate Professor Tamara McKeon, who is going to chair our next session, showcasing some of our excellent Aboriginal health research.
Good afternoon, everyone. I'd like to begin by acknowledging that we're meeting on the lands of the Kaurna peoples, and I'd also like to pay my respects to their elders and also acknowledge Aboriginal and Torres Strait Islander people joining us today in the room and online. As my bio says, I'm a Wallian woman, and doing the cultural protocols of welcome and acknowledgement of country is really important, not just for the sake of cultural protocol, but also for our well-being. I'm really looking forward to introducing the next 2 presentations. I'll be quick so we can remember it's a Friday afternoon. And we have 2. We'll do both presentations and have questions at the end. Our first presenter is David May, who's the Manager of Audiology in SALHN, looking at bridging the gap in early ear screening and intervention for Aboriginal and Torres Strait Islander children in SA. Thank you, David.
Thank you very much. First of all, before I start, I just want to make sure, can you just give me a wave up the back if you can hear me? Yeah, good. I just want to say, first of all, one of the worst questions you can ever say when you present to a group of people is, can you hear me? Because everyone says yes that can hear. So good that you've got me. I'm audiology, and I'm going to talk to you, if I can get my slides to work, whoops, wrong way, about a project that looked at, or a research project that looked at bridging the gap with ear screening. So we're talking about Aboriginal children and otitis media or ear infections in that population group. So I would like to acknowledge Annika Edler, who is the lead researcher in this project. Annika is off on maternity leave, so I've got the role of presenting on her behalf. So Annika's spent 12 months on this particular project and this significant piece of work. Okay, so a bit of a background behind this SALHN research grant. It's a 15-month project from March 22 to June 23. we received funding for a clinical lead and a range of other aspects associated with the project, Annika being that principal research lead. Also involved Russell Carbine, a Aboriginal health worker at Noongar Aboriginal Health Centre. He's also based out at Clovelly Park. I also like to acknowledge Jackie Stevens, Jacqueline Stevens from Flinders University, and Andrea McKivitt and Jess Stott and Margaret McCullum as co-investigators. So, just setting the scene, why? Generally, many mainstream health services have not been providing culturally sensitive Aboriginal health services. And many cultural and financial barriers that do limit access to health services within the Aboriginal community. So in attempting to change that, a lot of the focus has been on regional Aboriginal health services, and not a lot of research has happened in what occurs within our metropolitan area in terms of Aboriginal service delivery. So just reviewing the Department of Health and Ageing, when we look at a culturally sensitive approach to Aboriginal health services, it involves culture, history and connection to land, housing, employment, education and income, and community involvement, social networks and family support. So using those domains, we then ask the question of why are we investigating ear health within the Aboriginal community? Unfortunately, Aboriginal and Torres Strait Islander children have some of the highest rates of otitis media in the world in relation to a targeted population group. The World Health Organisation calls any incidence of a targeted problem within a community greater than 4% as a public health emergency. Unfortunately, when we look at Aboriginal communities, the incidence of otitis media or ear infections is sometimes 10 times that of non-Indigenous populations. So in some communities, we see ear infections as high as 70%, which is extremely alarming when World Health Organisation says 4% is a public emergency. Of course, we all know if we don't hear, it undermines language development, it undermines our learning, it undermines our education and social behaviour. So that's another good reason. And also we've had reports done here in SALHN that actually highlighted the fact that we weren't doing such a good job in terms of ear health within the area. And then further, we had Closing the Gap, which ceased in 2019. And that saw the end to the statewide Aboriginal ear health program. So there's some definite reasons why. We've got the population, the statewide programs have ceased, and some of the programs that have continued within SALHN, unfortunately, there was no real clear pathways for these children to travel down. So in 2020, Flinders Medical Centre Audiology implemented a pilot project that actually looked at a strategy directly with Aboriginal Family Clinic at Noongar in terms of how to see these children. It was an unfunded project. It was just a simple pilot project where we thought we'd try to gain a bit more of an idea of what happens within our own little area. So it wasn't funded, and we utilised the existing funding or departmental budget. It involved one afternoon a month, started with that half day a month, and it's built up to a full day now where ENT surgeons are actually coming along with us. And of course, one of the significant risks that we have is this demand that now is overstretching us and is certainly affecting the stability and the longevity of the program. So, the SALHN research grant, what were our aims? There were three main areas that we were out to look specifically at. We wanted to understand better the patient journey. We wanted to identify gaps and future opportunities, and we needed to build research capacity amongst Aboriginal and Torres Strait Islander staff. I'm sorry, I'm flipping through pages because my eyesight's not good enough to see these small size. So, what was our method? So, definitely an exploratory study, utilising mixed methods and a decolonising approach. We had parents and carers of children who had at least one occasion of service from September 20 to September 21. Utilised the Aboriginal family clinic staff. And I also want to acknowledge, in terms of the cultural integration into this project, that there was a significant Aboriginal voice in the whole project. The project had a steering committee, and that comprised of 50% Aboriginal members who were consulted throughout the project. And the data was analysed by 50% Aboriginal researchers. So, data collection. Participants from were pulled from the SALHN catchment area. And naturally, before we did any kind of research, we had the information sheets, consent forms and ethical approvals. We used yarning circles or storytelling to collate family and community stories of hearing and ear health care in a culturally and sensitive way. With an aim of trying to build relationships, explore individual experiences and relevant traditional ways of passing on knowledge throughout the community. Health journey mapping was also in there, with approach to reviewing patient healthcare interactions over time and across the settings. So, what did we actually find? There were 6 main areas that presented with the results that we found across this area. And I'd just like to go through each theme, if I can, one by one. The first was culturally appropriate health service. This theme was strongly evident across the research, where we found that the consumers and the staff yarning sessions highlighted the importance of access to culturally safe and aware health service. So parents reported the importance of Aboriginal representation from the Aboriginal family clinic, and had previously felt misunderstood and alienated in healthcare settings where clinicians did not adopt their approach to cultural sensitivity. So some of the quotes, and I'm just going to go through and present some of the quotes from this. We have themes up there now, such as being comfortable, understanding and knowledge of the Aboriginal and community members was a strong theme. Wanting to talk with other fellas about their problems, as they have a community relationship and understanding. And finally, learnings about cultural training, environment, and some of the logistics like getting a park at a hospital. The next section looked at, or the common theme, looked at sustainability and funding. And this I found to probably be one of the most interesting parts that really certainly I was enlightened by. So some of the concerns about sustainability and longevity of the hearing and ear screen program at Noongar, that they identified the fact that there's current model of fundings, but the need for training and resource were key themes that came out through the yarning sessions. So some of the direct quotes were one single Aboriginal health worker focusing on the project, which raised concerns about overburdening of one staff member, clients attached to one person, and also workforce planning. Here, also under that sustainability and funding, transport was highlighted in sustainability and funding themes, and the lack of transport to get to appointments. Trust. This theme came out quite commonly, and again, this was also a very interesting one. Both the Aboriginal Family Clinic staff and parents identified the lack of ongoing funding for healthcare projects had resulted in mistrust within the community. One staff member actually commented, the community get really used to being disappointed when projects were created, only for them to cease operation after a short period of time. So trust was a big issue, and I'm going to just let you have a bit of a read there for a moment, because certainly that ongoing funding and commitment to these kinds of projects, how they chop in and out according to different funding cycles, state, federal, etc., was a major theme. And a little bit more about trust. And it was interesting that accreditation came out in the research, that we have this big focus. Give us, tell us everything you do and what you do, and then left after that. Communication, of course, communication was a theme. Staff identified that communication played a significant role in whether patients attended the clinic. In many Aboriginal health services, DNA rates can be as high as 75 to 80%. So it's a significant component. Text messages were found to be one of the supporting ways of keeping them coming, but also knowing that there was an Aboriginal health worker, someone from their own group at the end of the phone that they can make inquiries with. Education. The parents and staff strongly felt that the importance of increasing awareness and education about the early identification of hearing and ear health issues, what the parents need to look for, and some of the common symptoms that they might actually see. So, recommendations for future service provision in terms of what has come out of the yarning sessions: multidisciplinary services, one-stop shop, holistic approach, the frequency of the visits, transport was a strong theme in there, and staff training. Also part of the research, there was a health journey mapping done on 2 particular cases. This helped, but it probably didn't give us a lot of information that the yarning sessions didn't already give us. There was a retrospective case note review, also part of the study, so we did a couple of different areas. And this occurred between September 20 and the September 21 case notes. 93 attended between the ages of 0 to 16 years. There was 175 consultations, which meant we had about a 60% attendance rate. Which is pleasing to see considering what the DNA rate is usually like. Referral sources came from registered nurses within the Aboriginal Family Clinic and the Aboriginal health practitioner. So approximately half of the children were discharged, or about 53% of those that attended by audiology. 17% required additional audiology, and approximately 30% referred to ENT, and of those, about 26% were discharged. So approximately 17 children stayed within care of ENT. So what are some of the recommendations that have come out of this study? We have a need for some ongoing funding considerations for a dedicated lead, funded for transport rather than by a case-by-case basis, increased cultural training awareness, more Aboriginal health practitioners trained in ear screening and operation and coordination of the ear screening program, combined audiology and ENT clinics at Aboriginal Family Clinic, phone call reminders via SMS, and parent education on ear health. Thank you.
Thank you, David. Straight to our next speaker, Sareed Martin, who is the current State Program Coordinator for the South Australian Aboriginal Diabetes-related Foot Disease Program being run by SAMRI. Thank you, Sareed.
Ninamani, thanks for having me. Bit of a hospital ball being the very last presentation for the entire week. Cheers, Lauren. But thank you for having me. I'll just introduce myself briefly. I'm a mum of 2 young kids. I am a podiatrist. I'm a master's degree student. I grew up on Bundjalung country in northern New South Wales, so relatively new to Adelaide, but I've lived on Kaurna country for the last 10 years, so I'm really happy to be here. I am a long-term SALHN staff member, but currently just having a bit of a break and gone to take on some work at SAMRI. I'd also like to acknowledge the Kaurna people and the land that we meet on today, and that we're meeting on unceded lands. I recognise the Kaurna people's cultural, spiritual, physical and emotional connection with land and waters, and I pay my respects to Kaurna elders past, present and emerging. And I'd also like to pay my respects to the authority of other Aboriginal and Torres Strait Islander people in the room today. So Duncan Langford-Glass, who is my co-presenter but unfortunately can't be here today, he's still going to present. So I'm just going to let him do his part of the presentation via video, and then I'll close off the end. So over to Duncan. How do I start it, Lauren? Oh, hang on.
Today's presentation is called Foot Stomp, Looking After Your Feet. Foot Stomp was funded through the Indigenous Health Program, a Commonwealth Government initiative. Our partners are SAMRI, SA Health, Southern Adelaide Local Health Network, and Flinders University. Yama, G'day, Ninamani. My name is Duncan. I'm a Kamilaroi man living on Kaurna country. I work at Flinders University in public health. My background is that of social work and mental health. I'm here today to talk about Footstomp, which shows the importance of the Aboriginal voice in podiatry care in southern Adelaide. There are about 4,500 Aboriginal South Australians residing in the Southern Adelaide Local Health Network catchment area. This is a community who are striving to create change and a better future for their children, despite experiencing significant disadvantage resulting from ongoing colonisation. Currently within Southern Adelaide, there are no public podiatry services, especially for Aboriginal people. There are well-established tertiary pathways for consumers with active diabetes-related foot complications, and anecdotally, there are limited Aboriginal consumer referrals and presentations. To date, there is no material published that relates to Australian podiatry services developed using a decolonisation framework, driven by the community needs rather than imposed by health service agendas. Our evaluation aimed to understand the needs and experiences for foot care service delivery for Aboriginal consumers and the community, and to determine how foot care delivery reflects community needs, experiences and priorities. In this project, we used Indigenous research methods. This included yarning circles, Aboriginal patient journey mapping and deep listening. These were applied by the Aboriginal researchers in exclusive Aboriginal data collecting spaces. We recruited Aboriginal community members to participate in the yarning circles that was conducted by the Aboriginal researchers. This was done in the Southern Adelaide community from April to May 2022. We provided participants with transport, refreshments, and a $60 gift voucher for their time. During the yarning circles, elders and the community members spoke freely and shared their foot care stories. During the analysis, the Aboriginal researchers collectively listened in to consider the data as whole before we sought a podiatrist's input, and then we conducted this in vivo. One of our important tools of Footstomp was our yarning guide. Our yarning guide looked like this. Data was collected from 33 Aboriginal community members across 4 yarning circles and 2 health journeys. We found 3 main narratives about foot health and foot care. Yarning circles with the community members demonstrated awareness of and knowledge about feet problems, foot care tools, and juggling feet care needs with competing priorities and limitations regarding resources within health. Experiences of foot care with health professionals and services were mixed. Good experiences involved taking time, explaining the procedures, and meeting the needs of their clients. The flawed experiences involved fear, pain, and having to accept culturally unsafe services. Access and quality were enabled when the participants felt safe, the gender protocols were observed, and the transport was provided. The role of the Aboriginal health practitioner in service delivery and being able to talk about using bush medicine were also important for the ongoing success of this program. Barriers to access and quality included miscommunication at multiple levels, a lack of workforce continuality, inadequate handover of patients across primary and tertiary services, and culturally unsafe practice. Our findings demonstrated that the Aboriginal people do care and have knowledge about their feet and feet care. And the quality of podiatry services, which included an Aboriginal health practitioner that worked in partnership with the podiatrist, that engaged respectively with patients and being open to considering cultural practices and bush medicine as part of the cultural safe podiatry care. In closing, I would like to share a quote from one of the yarns. And the quote is, "I tried bush rub from an Aboriginal lady in the community. Dad got it for me, but not from the clinic. I do not see her anymore, so I cannot get the bush rub. If the clinic had bush rub, I would buy it. I think that statement, that quote, is about the need of bush medicine.
Thanks, Duncan, in his absence. I just add something that got cut off the end of that. So something that Duncan shared with me when we were analysing the data together about bush medicine is that it's not only about having access to it, but it's a way for Aboriginal people to walk in two worlds, and that culture is a protective and a healing factor that goes alongside Western medicine and Western medical worldviews and practice. And the power of enabling somebody to reconnect to culture, country and Indigenous knowledge is vital for both protective and healing purposes. So that was something that, Duncan shared with me that really resonated. So I'll finish up a presentation today, and I'm going to talk more about what we've done with the results in a practical sense rather than delving into more of the research analysis type stuff. So some of you may know that this work was part of a broader Foot Stomp project that had multiple different arms. And the aim of Foot Stomp was to increase access to culturally responsive, preventative and proactive foot programs for the Aboriginal community residing in the SALHN catchment. Many of the findings from the research that we've implemented, they've occurred in a public health setting. I know everybody here mostly will be from public health, but these could be relatively easily picked up in any clinical setting. So for those of you who may be working in private practices, you could consider some of these points. And it's not just specific to podiatry. I think they could, go across multiple disciplines and disease processes. So the yarning circles inform many strategies that were implemented locally, including the commissioning the Foot Stomp artwork, which you saw really prominently in the, and hopefully you've seen it in real life along the corridors of podiatry and on the podiatry trolley as it rolls through the wards. This also became a really strong educative tool with community because it tells the story of keeping feet healthy and diabetic foot complications. We co-developed with community a range of foot education resources across multiple mediums, such as what you can see on the screen. And we hosted various Foot Stomp community events throughout the period. An aesthetic evaluation by Aboriginal consumers of the SALHN podiatry departments across the 3 sites were completed, and this led to the addition of the Foot Stomp artwork to make the space and unit more welcoming. Whilst artwork might be out of reach for some units or some clinicians in private practice, yarning participants told us that an acknowledgement of country that's up on the wall in your clinical space also showed them that they were welcome in the space. So it doesn't take a lot of, effort to find out whose land you're on and acknowledge that we are on their land. We also completed a cultural safety audit of the SALHN podiatry department with implementation plans, and a re-audit schedule has been put in place to work on strategies to continue to provide safer care for Aboriginal consumers. The podiatry staff have engaged with cultural awareness and safety training outside what is mandatory for SA Health, and I was really pleased of the commitment and from the department staff to continue their learning journey in this space. Following a decolonised framework and incorporating the feedback from the yarning circles, a business case has been established and a business case has been developed to establish a co-led foot health service at Aboriginal Family Clinic. It's not a podiatry service, it's a foot health service. It's currently under consideration by SALHN, so fingers crossed. The difference in this business case is that everything that is in it has come from community and the results of the work that we've done here. In current practice, I think taking a decolonised approach to service development is not unique in healthcare, but it's certainly not common, I believe. However, to provide safe and effective foot care for Aboriginal consumers or any disease pathway or issue that people are facing, designing and delivering services with Aboriginal staff and community is essential. finally, I'll just leave you with a few, excuse me as I skip. I just wanted to share a little bit about my experience and a few of the learnings whilst I've gained working on Footstomp, but has continued now into my role at Wadley Paringa with SAMRI. Aboriginal research methods, whilst appearing qualitative based, are different and therefore need to be approached differently. Non-Aboriginal researchers, such as myself, need to be aware of and accept the responsibilities of our Aboriginal research colleagues, and that they have a responsibility to culturally respect the data that is being collected. There are some parts of the research process that were not appropriate for me to be involved in, despite me being keen as mustard and incredibly keen to learn about the methodology. I needed to take a step back, and I was very graciously guided by Tamara, Shane D'Angelo and Duncan, who we collaborated together on this. Research involving Aboriginal people should no doubt 100% be led by Aboriginal researchers and the community. If you aren't starting at that point and you're wanting to engage with the community, take a step back and start again, would be my advice. My personal decolonising journey is ongoing. I've got lots to still learn, but I'm challenging my own biases by listening and learning. The Flinders Uni team, Tamara, the broader SALHN Aboriginal health staff were incredibly generous to share their knowledge and culture with me during Footstomp, and it's made the experience one of the most humbling yet rewarding of my career. And I'll leave you with this. We've all got a responsibility as clinicians to do our part towards closing the gap for Aboriginal and Torres Strait Islander people. I would encourage you and challenge all of you to start or continue on your own journey to discover, reflect, acknowledge, listen and learn to ultimately provide safer care to all people. And as I'm not currently working at SALHN, I think I can step outside the public sector space for a second and challenge you to really engage with the referendum. I'm not telling you how to vote, but I am encouraging you to find out what the voice is about and make a decision based on facts rather than fear. Thank you. And as I'd say, I'd just like to acknowledge the co-authors, Duncan, who you saw in the video, Shane D'Angelo and Tamara McKeon. Ta.
I think there is time for at least a couple of questions for our two presenters. I'll let Sarade out, perhaps that will work. And also ask David to join us. And Lauren's got a microphone. Ripper. So, any questions? Any comments? Oh, and the Slido, yes. Will the questions come up here on the Slido? Oh, they'll actually come. Ha. I think it's the Friday afternoon. All right. I can see that there's probably less of a inquiring mind at this hour.
Can I just ask a quick question? So you've got really excellent findings, and I know, Sarade, you said that you've got a business case in. But how can we make sure that this is translated into practice?
I think we lean on Aboriginal health significantly in this organisation. Like all of us, they run on the smell of an oily rag, if not even more so than some of the other big units. In-kind support only goes so far. So I think the organisation actually has to put their money where their mouth is, to be honest, actually. There's only so far that in-kind support can go. That said, on an individual clinician perspective, I think like I said in my presentation, I think we've all got a responsibility to engage in understanding culturally safe care the online SA health training does not cut the mustard, I have to say. So there's lots of opportunities. Go up and visit Colebrook. There's a self-guided walk in nature that you can listen to the listening posts and get an introduction to the stolen generation that lived just up the hill, something that you can do off your own back. Go and talk to your Aboriginal health staff. Learn their names. Learn where they're from, who they are. You got Tamara or David? Sorry, I might sound like I'm on my...
I think I would totally agree with what you've said. Funding is a major issue, and we are at the point where we have to put our money where our mouth is. I think there's an element of, too, we need to embrace a philosophy that we are working with a group of people who have had negative experience and have some learned behaviours. For example, walking into a hospital institution, many of them relate that to their family, community, not coming home. So they don't like to come into a hospital environment. So we have to think broader and how we can actually provide health outside of an actual building.
Thanks. I might add 3 things and then perhaps we'll call it a day or a week. I'm pretty sure that was my mum's bush rub that was being talked about. So I can get it. I've lost family in this hospital, little babies, older people. It's always an interesting experience to come here and do the best that I can do in my work with SALHN as well as with Flinders. It's a very real experience, what David was saying, and I think we need to respect that for everyone. And the public healther in me just won't give up. We've got a really good model of continuous improvement in this hospital at a unit level. We actually have the bones to be able to take a decolonising approach to implementation science, lift that up to the whole of region perspective, and actually start to funnel our research findings, particularly research funded by SALHN, into clinical services planning and into the EMR so we can actually work real time with data. So I think there's some real opportunities. And I really want to thank both David and Sareed for bringing such excellent presentations for us to finish our afternoon. Thank you both. And thank you all.
Look, before we have a couple of things to do before we finish, but just before getting on to those, I really just want to thank our, Tamara and our last 2 speakers. Tamara, you know that you were not unheard. I want to acknowledge that we've got local MP, Nat Cook, here. She has specific interest in this, and Nat, I hope that was of interest to you as well. It was of interest to me. Thanks so much, Nat, for being here. We really appreciate it. The final task today, so we'll hold you a little bit longer, is it's a great task really for me to be able to do this. I want to acknowledge that we've had wonderful support from both Flinders Foundation and from the Hospital Research Group. We couldn't have done this without you, so thank you so much. I think Ross for sure had to leave early, so unfortunately we can't get Ross down, but Paul Flynn, can we get you down? And I just want you to come down, meet everybody, and maybe just say a few words, because we're very proud of the work we've been able to do with the inquiry round. You've heard some of it today. You've heard how important it is, and we can't do it without your help.
Thanks, everyone. The SALHN Research Round is a really good example of focusing all of the attention of the clinical researchers on unmet need in the community. Some of the things I've heard this afternoon really go to prove that. We are very happy to partner with Flinders Foundation to be able to partly fund some of these programs. It's what we're all about. I often say to people, if not us, who? So thank you for all of the effort that you're doing to improve the healthcare of all Australians, and we're very proud to be part of it. Thank you.
Thanks so much, Paul. Now, I'm going to read out, we had a great round. In fact, a lot of the reviewers, it was extraordinary. The reviewers all wanted to review, and a number of them came up to me and said, wow, the quality was really high. We haven't been able to fund all of them, but we're going to announce the people who we are able to fund. Now, within the office, we couldn't have done this without Dominic Howe, who's just sitting over here. So Dom has been absolutely the glue. So he's the glue. He got all of the reviewers to review. He pulled it all together. He pulled the marks together, and he's kept me on track a little bit with this, with the rest of the office. So thanks very much, Dom. That's been fantastic. I'm going to, I know we're short of time. I'm going to read out the project. We'll get you to come down, receive this. We're going to get a photograph. Yep, we'll get a photograph, and then and we'll do it as fast as we can if we can. Okay, so don't worry. So Nikki Marshall, can you come down? This was a project, can textured insoles reduce the amount of toe walking in children with sensory needs, a randomised controlled trial. So toe walking is where the heel doesn't make adequate contact with the ground, and it affects about 5% of typically developing children and 20% of children with autism spectrum disorder. So this study aims to investigate the use of textured insoles as a sensory aid to determine the efficacy as low-risk economical treatment for children who toe walk. So congratulations, Nick. I'm trying to be quick. So I've got, that's, are you all going to have, oh, excellent. Thank you very much. Well, that's really great that we've got, that you're going to help us with this. I know you've got a special association with SALHN as well, so that's terrific. So can I ask Malcolm Battersby and Ben Riley to pop down? So this was a project, principal investigator was Professor Malcolm Battersby. My APT-SP, co-design and pilot of nationally scalable intervention of people who present to an emergency department with a suicide attempt. This project's going to trial a novel intervention, My APT-SP. These patients or these people will receive 7 sessions of phone or video cognitive behaviour therapy. You've just heard a bit about CBT today. And their trusted other 4 sessions assisted by Mind Tick, Mood, and Safety Plan app. It builds on a pilot study. I know you reported this a couple of years ago, Malcolm. I really enjoyed that, which you did with 13 participants at that time. And successful completion will inform sample size required for a full randomised control trial. So congratulations. Okay, the next award is, these are not random, they're actually grouped together in terms of the 4 fields of inquiry. I think we've got that. Oh, I should keep pushing. Okay, yeah, all right. Thank you. All right, thanks. Yeah, I need a lot of help here. Oh, I'm sorry, I'm pushing. You're pushing, okay, all right, good for you. Okay. Amelia Searle, if you could pop down. Have we got Amelia here? Great. Congratulations, Amelia. This was for a project, does movement-based self-management program improve outcomes for people with chronic low back pain following their lumbar facet procedures, a randomised controlled trial? So I think we heard from you before, Amelia. We know that you're doing great work. This is a group-based exercise program where people will either have the group-based exercise program following rhizolysis or just rhizolysis alone. So congratulations, look forward to hearing the results from you. The next award is for Catherine Ames. Is Catherine here? You are. Excellent. If you could pop down, Catherine, thank you. This is a project entitled Evaluating Innovations which aim to prevent and managing challenging behaviours in hospital settings. So behavioural and psychological symptoms of dementia are common and can be very difficult to manage in clinical settings. There's a range of different innovations which have been developed and trialled in small clinical studies, and these include interactive technologies such as TOVA TAFL, is that right? Good. Virtual reality, sensory devices, and these will be part of a clinical trial that'll test these implementations. Congratulations. Okay, Rowan Meagle. Rowan, excellent. Come down, Rowan. This is for a project determining the value and relative importance of elements, themes and logistics of a prehabilitation for cancer surgery program. From the perspective of consumers and health leadership staff, a discrete choice experiment study. So this is aimed at patients undergoing major cancer surgery who are at risk of adverse health outcomes, and it's going to look at multimodal prehab programs, including exercise, nutritional and psychological support, and it will develop a discrete choice experiment for health service planning tools. So congratulations. I'm pretty sure Rob Baker's still here. I can see you there. Can you come down, Rob? Congratulations, Rob. This is for a project evaluating and implementing an e-mental health resource for Aboriginal and Torres Strait Islander patients during admission for cardiac surgery, a continuous improvement project. Now, you may or may not be aware that we have a significant Aboriginal and Torres Strait Islander population undergoing cardiac surgery. It's about 20% of the program here. I think it's the single biggest program in the country. But there's no specific patient-related outcome measures for this group, and this is what this is going to aim to do. So congratulations, Rob. Thank you. No, I think Justin Prendergast is not here. I think he's been away this week at a family event. But he's received this award for a project titled Improving Patients' Oral Health through the implementation of evidence-based interventions in SALHN. He's partly, Carly, congratulations. Thank you for coming down. I didn't see your name there. This is a multidisciplinary consumer collaborative application for contemporary implementation framework that'll be used to foster a learning improvement culture. Now, you may wonder if you're not, and this includes people like me, who are not that well informed about oral health, but it is profoundly important and associated with evidence of hospital-acquired pneumonia and many other complications. And so this is really important stuff, and I think there's quite good evidence around this, and this is a great program. So I'm really pleased it's been funded. Now I've got Lydia Forbes and Andrea Bass. Yes, excellent. Thank you for attending. Please come down. This is a project evaluating the effectiveness and implementation of a cognitive remediation program for residents of a mental health community rehabilitation centre. Now, if you were lucky enough to be here on Monday afternoon, Andrea had organised a great session on mental health, and we heard a heck of a lot about some of these chronic centres and some of the work that goes into that. So I'm really pleased that you've got some funding for this as well. Congratulations. Now, this is for Arduino Mangoni, but I think Dr. Hua Xin NG. Excellent, thank you, Dr. NG. This is for a project entitled Developing Innovative and Holistic Prescribing Strategies in Patients with Multimorbidity Using Network Analysis. So this will use much needed knowledge regarding the following things: how different disease patterns coexist in individual patients in a way that's easily interpretable to clinicians and consumers in a highly dynamic, demanding healthcare environment, the critical elements of holistic prescribing in multimorbidity, and the effects of multimorbidity phenotypes. So, congratulations. I'm rushing because I've got about another 6 or 7 of these to go, and I can feel everybody's edging. But look, these people have put a lot of time and effort into this, and we're we're very proud to be giving these out. This was for a project, the experience of sleep for palliative care patients and their carers. And the principal investigator was Tim Tobit. I don't think Tim can be here, so Carolyn Phelan and Anne Walker, yes, please come down. So I think it's perhaps not surprising that there is significant sleep disturbance in patients who are having palliative care and in their primary carers. And this study will examine these disturbances by using actigraphy, non-invasive monitoring, validated sleep questionnaires and functional assessments of this. Congratulations. Dr. Jessica Smith, is Jessica here? Right, it's wonderful that people have come along, thank you for that. This is a project entitled Bridging the Gap, a pilot project assessing efficacy and safety of conscious sedation pathway for consumers with neurodevelopmental disability to access early health intervention. So this project is using a conscious sedation pathway by a non-anaesthetist, so it's going to be informed by anaesthesia. And it's going to be, the co-design includes Autism SA consumers and clinicians. So I think the co-design practice, that's the way to go. So congratulations. Jaya Ramakandran, not much good with that, sorry Jaya. For a project, the role of human leukocyte antibodies, non-human leukocyte antibodies in liver transplant dysfunction. So Jay is one of our liver transplant physicians. We run a great program here, and I know this is very important, but about 10% of transplant patients receive complications. Many of these need to be retransplanted, which is a major issue. So the proposed study will test for antibodies in the blood of these liver transplant recipients and look at the relationship between those antibodies and complications. So congratulations, Jay. Frank Guerrero. Thanks, Frank. This is for a project, a nurse practitioner-led wound management basic science project for the identification of cellular senescence biomarkers in diabetic foot wounds treated with a biodegradable synthetic matrix. So this is a nurse practitioner-led project which seeks to explore the impact of cellular senescence in the healing of diabetic foot wounds with the view to establishing a biomarker-based test to guide clinicians on who would benefit most from this treatment and to inform targeted therapies. So congratulations, Frank. Is Elizabeth Kapoor here? This was thank you, Elizabeth. Congratulations for this. An evaluation of a novel gastrostomy feeding tube, PEG-ED, with an interactive decision-making tool for patients and their families living with motor neurone disease. So I think most of us would be aware that motor neurone disease is a disabling disorder. A lot of these patients require PEG feeding because of swallowing difficulties with their upper airway. And this is an app that's going to provide a centralised hub and interactive resources for these patients and their carers. So congratulations. Fiona Taverner, you can see there, Fiona. This is for a project entitled Electrical Impedance Tomography Assessment of Lung Homogeneity in Infants Undergoing Inguinal Hernia Surgery, a prospective cohort study. So electrical impedance tomography is a non-invasive radiation-free technique which can look at the lung, not only in small babies but in adults as well, all sorts of people it's been used for. And this will look at what's happening to those lungs in those children undergoing inguinal hernia surgery, because obviously we can see collapse of the lung or partial atelectasis, those sorts of problems which might lead to a requirement for post-operative ventilation, as we've heard before in the previous stuff. So I think that's great, and I'm hoping that we can all learn a bit more about EIT. Thanks, Stan. Jia Jin. Jia, come on down, please. So this is, have we got others here? Is Steve Glitcher, Ubo, Catherine here? Just, Catherine, come on. This is for evaluation of the effectiveness of the Flinders Medical Centre SOC, the SALHN Operational Centre initiative in ICU patient discharges and patient outcomes, a mixed method study. So the SOC has been implemented here since around 2021, and in addition, effort to improve flow. To get flow out of the emergency department, particularly in the highest acuity areas such as the resuscitation room, you have to get those patients, often they're going to ICU. To get into ICU, you have to get patients out of ICU to the ward as well. So this is going to be looking at the efficacy of that. So well done, team. Okay, I did put the afterburners on, so we're on the very last one of this, which is for Dr. Kasani Manuel. Is Kasani here? Congratulations, thank you. This is for a study entitled Leveraging Human-Centred Design to Develop a Model of Care for Older People with Post-COVID Conditions. So post-COVID conditions, long COVID, I think we think it really exists now. We've been worrying about that, but I think we're now realising this is going to take a lot of work. The Australian Government has identified frail people living with post-COVID as a priority, and this is going to start looking at some of those issues. So congratulations for that. Thanks, Nat, for helping us with that. That was really a treat. Look, it's the end of our week. We think it's gone pretty well, but we want to do better every year. We want to do better next year. So we will be coming and talking to people. Please tell us what we can do better. The attendance today is great. Now, there's a good reason for that, but I think it's also been wonderful sessions all day as well. You've heard, we couldn't have done this without our supporters such as Flinders Foundation, Hospital Research Foundation. We couldn't have done that without people, Simon, Lauren, Dom, everybody, Catherine. We couldn't have done it without the people who presented. We couldn't have done it without an audience. We need the support of everybody. So I think we've done a great job. I think we've got the mix about right this week, but we really like to hear from everybody about how we can do it better. And, we opened the SALHN Research Hub today. It was one of I think the second now dual-named site here. And we're pretty happy with that. Please come and visit us as well, because I think it's only through interaction and collaboration that we can improve what we're doing. So thank you for staying here on a Friday afternoon. For the winners, congratulations. For people who missed out, we'll be trying to find funding for you. But have a go again next year if we can't do that. So thanks very much, everybody.